Thank you very much for coming today. I know a number of people have come a long distance for this, which I think reflects the affection, the impact, the pleasure of working with Colin. I have to say, from my perspective, though, the day I met Colin was the worst day of my professional life. Because on that day, after several years of negotiations and discussions with various companies about an opportunity to demonstrate the value of lowering cholesterol and cardiovascular events in what was to become the heart protection study, the funding for that project was withdrawn by the company. So I don't know that I was on my most sparkling form when I met Colin, as we tried to consider what we were going to do next to recover from this. But we did, and Colin has been a very major part of that kind of recovery in the contributions that he's made to the department, the way in which he has extended the work that we were doing into other areas. At that time, certainly within CTSU, Clinical Trial Service Unit, which was a small part of what has now become the Nuffield Department of Population Health, we were very, very focused on people with coronary disease. As you'll hear, for those of you who are not familiar with all the different aspects of Colin's career and the contributions that he's made, he kept on saying there are other organs that we needed to look at the ways in which risk factors for cardiovascular disease were relevant for many other conditions. And the kind of genesis of the work that's been done within the department, but also the impact that the department has had on work both nationally and internationally in terms of understanding the relevance of renal disease to cardiovascular complications, the development of a whole strategy on both epidemiological studies, the risk factors for bad outcomes with renal disease, but also ways in which in clinical trials to produce improvements in renal disease has very much been driven by Colin and his focus on ensuring that we did think beyond the heart. Again, as you'll hear, Colin's very much a person about brains. He is a person with an extraordinary brain, I think. His ability in maths, his ability in medicine, but also his ability to really help us to understand how better to treat people who are having complications related to their brains, and particularly the work he did on stroke. And when I have talked to Peter Sandico about the whole period when the development of treatments for stroke were being evaluated, and the potential benefits of using thrombolytic therapy, so moving from the idea of using thrombolytic therapy to dissolve clots in the heart to dissolving clots in the brain, a very much more complicated area where the kind of balance between dissolving the clot and dissolving the brain with bleeding became much more nuanced. I think there again, Colin has made an extraordinary contribution. And when I think about what he might do next, I kind of realize that, yeah, he's a very, very good scientist, but he's a lot more than that. And in that area, for example, it was his diplomatic leadership of a process of trying to work out what the reality was, what thrombolysis could do, how it could be used in the setting of the emergency setting with stroke, and getting people with disparate views, often strongly opposing views, sometimes even physically strongly opposing views, and getting people to actually accept what the data showed was another aspect of Colin's quiet diplomacy. And so he may be moving to the Middle East. He may be going there to sort out some of the diplomatic problems we have in Ukraine after he stops working full-time here, because he has got these amazing skills of getting people who don't want to work together to work together, who don't agree on the conclusions to agree on the conclusions. And again, I saw it, at least from afar, in the work that he did with the European Society of Cardiology, where his leadership of the guidelines committee approach to make sure that it really was an objective and as unconflicted a process as possible, again, took people who had serious conflicts of interest, who were benefiting enormously from a system that wasn't quite right, and managed to, again, through this quiet diplomacy, to get the right outcomes. So it is that kind of combination of fantastic scientific focus, real ability, both from a mathematical and medical background, but also, and I think most extraordinarily, this fabulous skill of getting people to work together that, for me, kind of characterize what Colin has done. And after that worst day of my professional career, one of the best aspects of my professional career, and I suspect for many others, has been the opportunity to work with Colin, to learn from Colin, and to see what one could do if one wasn't quite as impatient as one is, to actually get progress where it seems like progress is impossible. So I'm really looking forward to the rest of today. I'm also looking forward to continuing to work with Colin, because I have told him he's not actually allowed to leave. I think we should have a fantastic program later on. And we will start now with the first of the talks by Jonathan Emerson, who actually, I should mention, with his talk of the beauty of meta-analysis, was definitely the partner in crime with Colin on straightening out the situation with acute ischemic stroke and thrombolysis. So, Jonathan, over to you. Thank you very much.
Okay, good morning. Thanks, Rory. Good morning to everybody. It's really nice to see you. Colin, you asked me about 6 months ago if I'd give this talk. And I said, yeah, of course, there's no problem. And then he said, why don't you just give the talk, the title I want it to be The Beauty of Meta-Analysis. And I thought, yeah, okay, that's fine. 6 months away. Of course, I'd like to do this talk. And then about 2 weeks ago, I thought, right, I'm going to have to start thinking about what I want to say in this talk. Anyway, I realized, I'm not actually sure how to start. Normally it's easy. You talk about this subject, this study, this trial, background, blah, blah, blah. I thought, I'm not quite sure what to do. So I do what everyone seems to do these days when they're not sure what to do, is I asked ChatGPT. And I said, ChatGPT, firstly, do you think meta-analyses can be beautiful? And to be fair, it gave a very nice answer. It said, yes, meta-analyses can be considered beautiful in several ways. Scientific rigor and clarity, they often represent the pinnacle of scientific rigor, combining data from multiple studies to provide clear and reliable conclusions. This is a form of intellectual beauty. I thought, that's good. Well, visual representations, the graphical elements can be visually striking. They can be aesthetically pleasing. I thought, fantastic. Synthesis of knowledge, the process of synthesizing itself can be elegant, and that's true. And of course, the impact on our understanding and on policy. Meta-analyses have significant implications for clinical practice, public health, and further research. This is itself a beautiful outcome. And these ways, meta-analyses can indeed be appreciated for their beauty in terms of their methodological excellence and broader contributions to society. I thought, fantastic, I've got to start. I might as well at least I've got one slide in. And so I was on the web and I thought, well, where else shall I look? I thought I'd go to PubMed Central and find out what actually have we done together over the last 20 years. And for those of you who didn't think I could do a literature search, it turns out that I can. So Baigent, author, plus Emberson, author. Let's just see what it returned. So I found 63 articles that we've published together as named co-authors, and about half of them have been meta-analyses, and they include, meta-analyses related to antithrombotic treatments, blood pressure treatments, cholesterol, coxibs, gastroprotectants, Marfan, stroke thrombolysis, and some other things as well. And they've been published prominently. About half of those papers, half of those 28, have been published in the Lancet. Another 4 or 5 have been published in other Lancet journals, and a few others have been published elsewhere. And they've been cited in a lawful, a lot, 30,000 citations just from those 28 papers. And in about 2010, 2011, Colin, you asked me if I could help you update the version of a chapter you wrote in the Oxford Evidence-Based Cardiology. And I think this is a chapter which you wrote previously in the second edition with Richard and I think Richard Gray and I think Sarah Parrish as well. And it was a relatively minor update Salim Youssef wanted, and I helped a little bit with that. But for me, it really, helping, well, initially read what the previous chapter looked like and then change 2% of the words really helped me figure out, yeah, this is what I think about meta-analysis. This has really helped cement my understanding, and it's how I've tried to teach this subject since. So all of my students, whenever I talk about meta-analyses in clinical trials now, this is the thing I point them to as the essential reading. Okay, but for those of you who maybe aren't so familiar with meta-analyses, well, what are they and why are they useful? So at its very simplest level, a meta-analysis can be considered simply as a statistical method for quantitatively combining the results of different studies in a way that preserves assessments within each study and provides some kind of meaningful average effect across the included studies. And this can be done in meta-analysis of trials, it could be a meta-analysis of observational studies. The principles are the same. And they're very often useful, and they're particularly useful whenever there's uncertainty, because individual studies are very rarely big enough to answer all of the questions as reliably as we would like. They're useful to help answer questions that were never posed by the individual studies, including timings of effects, adverse effects, whether effects depend on other factors, whether there's effect modification, and also to settle controversies, for instance, to test hypotheses that might be raised by individual trials. And we've used meta-analyses in all of these regards over the last 20 years or so. And of course, by increasing the number and also the heterogeneity of participants, it helps bring clarity by reducing random errors. Of course, meta-analyses are only as good as the trials that go into them, and their reliability can be affected both by biases that occur within the individual trials themselves, perhaps related to inadequate concealment of treatment allocation, inadequate blinding, inappropriate exclusion of participants after randomization, but also biases related to the selection of trials. And a particular small-scale meta-analyses may, not always, but may be unreliable if publication bias results in emphasis on the more promising of these small trials results being published. And just to say, everything I'm going to talk about now is in the context of meta-analyses of randomized trials. So I'll give you an example. This is something which Colin was involved with in the mid-1990s, the ISIS-4 trial. But before we get to the ISIS-4 trial, we'll describe a little bit about what the thinking was around the early 1990s. So around that time, there was extreme excitement about the potential use of magnesium therapy in acute MI. And I can see Salim's just walked through the door. Perfect timing, Salim. So around about that time, there were, depending on how you looked and how well you looked, there were about 12 small trials that collectively had randomized 2,400 patients with acute MI, randomized them to magnesium versus not, and then this is the effect on death within the first 4 weeks, I think, suggesting that magnesium therapy might perhaps halve mortality within the first month, 72 versus 151 deaths in that first month. Then there was a much larger trial done in the early 1990s called the Limit 2 trial from Leicester, which individually had randomized about the same number of participants as all of the other previous trials combined. So 2,400 patients in this trial. And individually, it was a non-significant reduction in mortality, but it was still supportive of the hypothesis perhaps suggesting that magnesium therapy reduced mortality by about 1/4. And as you can see, these 13 trials combined now, the average result would be somewhere between 1/4 and about 1/2 reduction in mortality, highly statistically significant. And then, of course, Richard and Rory and Salim and others, and yourself, Colin, you were on the steering committee of ISIS-4. ISIS-4 randomized nearly 60,000 patients to magnesium therapy versus not. And this was the result: 2,216 dead versus 2103 dead. ISIS-4 was a 2x2x2 factorial study, which means that there were 3 tosses of a coin. The first toss of a coin came up heads. You're randomized to, what was it, captopril. The second toss of the coin, if that came up heads, you received mononitrate. And then that third toss of the coin, it was magnesium or not. And this was the result for magnesium versus not. Absolutely no reduction in mortality. In fact, a marginally non-significant increase in mortality. Of course, this result wasn't believed by everybody at the time, and there was another trial in the US called the MAGIC trial, which was big, albeit 10 times smaller than ISIS-4. And the MAGIC trial confirmed the result that was seen in ISIS-4. So that if you put all of these results together, with nearly 70,000 randomized patients, absolutely no effect on mortality within the first month. This is what's called an information-weighted meta-analysis. Incidentally, if you do a random effects meta-analysis, you would get the impression that mortality was reduced by 1/3. Now, this is wrong, and this is not for further discussion today. If you are interested, Richard has walked in and can talk to you in the coffee break. So 1994 was a very busy time for Colin. He wasn't just working on the ISIS-4 trial, but he was at the same time involved in the antiplatelet trialist collaboration, which was an enormous task. So this is one slide from the antiplatelet trialist collaboration. It really demonstrates the value of including all trials, published and unpublished, to try and reduce the likelihoods of publication bias. So this is one slide from the ATT. Published in 1994, 145 trials, 70,000 high-risk patients, 30,000 low-risk patients. And as you can see in the graph here, antiplatelet therapy definitely protective in each of the 4 main high-risk categories. Those with prior MI, acute MI, prior stroke or TIA, or other high risk. And in each of those groups, risk was reduced by about 1/4. And the conclusion that among a much wider range of patients at high risk of occlusive vascular disease than is currently treated, some years of antiplatelet therapy, chiefly medium-dose aspirin, offers worthwhile protection against MI, stroke, and death. And again, these are results from a meta-analysis, and I think this is also another beautiful meta-analysis for a different reason. Okay, for most people, working on the antiplatelet trialist collaboration and ISIS-4 would be plenty for a single year, but not Colin. So 1994 also was published the fibrinolytic therapy trialist collaborative group main chief report. And for me, I think this is my favorite meta-analysis picture that I found. I was hoping it would be one of the ones I worked on as co-author with Colin, but it wasn't actually, it was this one. So this is from 1994. This really demonstrates the value of individual participant data to reveal patterns for how treatments work. So the FTT included 9 trials, 60,000 randomized patients with suspected acute MI. It found an excess in mortality on days 1 and 2, especially in patients presenting late. But that was outweighed by a much larger mortality benefit on days 2 to 35. It found similar effects in different types of patients, but critically bigger benefits with earlier treatment. So you can see the graph on here, patients treated within a few hours had by far the biggest absolute mortality benefit. Then you get this very nice straight steep line relationship between the benefit versus time to treatment. Okay, I'm going to switch tack a little bit now. So we've talked about 3 meta-analyses so far, all from the mid-1990s. That was really quite beautiful. Also in the mid-1990s, others, people in Oxford, but also others, were thinking about cholesterol and coronary heart disease. And I found this paper from Wold and the BMJ in 1994, and it really described how the very best meta-analyses are informed by the very best epidemiology. So in 1994, this paper was published, and what it shows, this isn't a meta-analysis, but these are 10 different studies. all of men actually. And in each of those 10 different studies, what you can see is a very steep, straight line, log linear association between the average cholesterol level, this is total cholesterol in these studies at the time, and the incidence of ischemic heart disease. And what it demonstrates is this log linear model for the relation between risk of IHD and cholesterol fitted the data well. That was their conclusion. And in a large study of men screened for inclusion in the multiple risk factor intervention trial, that's the biggest one in the top right-hand corner. You can barely see the confidence intervals. It was a pretty much perfect fit. So expressed simply, what does this mean? It means that a constant absolute difference in serum cholesterol at any point on the cholesterol distribution was associated with a constant percentage difference in the risk of IHD. And this work, and as well as other work that was going on by others, including in Oxford at the time, really determined how the cholesterol treatment trialist collaboration was then designed. So the cholesterol treatment trialist collaboration, which Kirsty will talk about in detail, and it's published over many years, almost exclusively in the Lancet. This particular slide was taken from the 2010 paper, at which point there were 26 trials contributing individual patient data on 170,000 randomized patients. Some of those trials tested a statin versus placebo. Some of those trials tested a high dose of a statin versus a low dose of a statin. And what I found that lowering LDL cholesterol with a statin for each 1 millimole per liter reduces risk of major vascular events by just over a fifth. It also showed how further reductions in cholesterol with higher dose statins produced further reductions in risk. And then critically, identical to the epidemiology, no evidence of any threshold within the cholesterol range study, suggesting that 2 to 3 millimole per liter LDL reduction would reduce risk by 40 to 50%. And you can see this in this forest plot on the left-hand side. So these are the effects per millimole per liter LDL reduction, which was pre-specified on the back of the epidemiology. And you can see here that whatever the starting cholesterol was of the participants, reducing it by 1 millimole per liter reduced the risk of major vascular events by just over 1/5. So again, another beautiful meta-analysis. Okay, now pre-specification is useful and has been extremely useful for the CTT, but sometimes you need to let the data tell their own story. And Colin, you've often said to me in the past how you can't write an instruction manual to solve a murder, and I like that. And I Googled it, and it turns out you can, because lots of people have written books called How to Solve a Murder. But actually, what they're describing is the principles of how one might go around trying to solve a murder. So gathering evidence, seeing where the evidence then takes you, then exploring other avenues, and then finally being able to present the evidence in a way which convinces everybody about the guilt of a suspect. So pre-specification is useful, and it was done in the stroke thrombolysis collaboration as well. But sometimes you do need to let the data reveal themselves, if you like, and point you to actually what the true effects of the treatment are. And this is an example which I've quite liked in the past. So in the stroke thrombolysis collaboration, there was 9 trials, 7,000 patients with acute ischemic stroke. It was testing alteplase versus not. And one of the outcomes we'd pre-specified we'd look at is 90-day mortality. And this was the result overall, 608 dead versus 556, relative risk of 1.11, with a 95% confidence interval, which, depending on your prior prejudices, you might convince you that alteplase was a bad idea, or might convince you that there's no need to worry about mortality. But the overall diamond here, in my opinion, is really quite meaningless. It's masking what's really going on in the early stages versus later stages. So if you break this result up in the first week, the rest of the first month, and then months 2 and 3, then what you see here in the first week is a significant excess of mortality, exclusively due to the risk of death from the fatal ICH, 91 versus 13 deaths, and 191 versus 191 deaths from other causes. That's week 1. And then for those who survived week 1, no excess in mortality. And in months 2 and 3, no excess in mortality. So the overall results from this meta-analysis, which Peter's going to talk about, alteplase significantly improves the odds of a good stroke outcome when delivered within 4.5 hours, earlier treatment resulting in larger benefits, similar proportional effects irrespective of age or stroke severity, which we pre-specified we wanted to look at. And with regards to this analysis, there was this early increased risk of fatal intracranial hemorrhage, but that was it was offset with no significant effect on other early causes of death or on later causes of death. Okay, one more example. Meta-analyses of networks of randomized controlled trials. These, everything I've shown you so far has been pretty straightforward. A versus B, add it up, make a conclusion, do some extra analyses. But sometimes things get a bit more complicated than that. So what do I mean by a network of a randomized comparison? So I'm going to give you an example outside of medicine initially. So here's a network of comparisons. So these I'm going to show you some data on international men's rugby matches from 1871 to 2024 between Wales, Scotland, and England. Okay, so Wales have played Scotland during that time 130 times. Wales have won 75 of those games. There have been 3 draws, 52 Scotland wins, so which means no one's interested in a draw. So a Wales win-loss ratio of 1.44. Okay, what about Scotland versus England? Kirsty, I'm sorry about this. Scotland have played England 142 times. Scotland have won 47 of those games. England have won 76 of those games. Scotland's win-loss ratio is 0.62. So what does this mean? If Wales never, ever, ever played England, and trust me as a Welshman, sometimes I wish that was the case, this is what you would expect the Wales versus England results to be. 1.44 times 0.62 is 0.89. That's what you'd expect the Wales-England win-loss ratio to be. And as it turns out, that's exactly what it is. The actual Wales results, 142 games, 61 Wales wins, 69 England wins, win-loss ratio of 0.89. And perhaps that isn't that surprising. You know, these teams play each other once and only once every year for the last 150 years. Very occasionally, the last 25 years, they've played a friendly or they've met in the World Cup, which, you know, messes the network up a little bit, but it's a near perfect network. And as it turns out, what you predict indirectly is exactly what was observed directly. Okay, so why am I talking to you about rugby? So this is going to move now to the COXIB and traditional NSAIDs collaboration, which involved hundreds of drugs, but I'm just going to look at 3. Diclofenac. COXIBs is a single class, which is a crude way of thinking about COXIBs, but let's do it anyway, and placebo. So Wales are diclofenac in this case, Scotland are the COXIBs, and England are the ineffective placebo. So for various reasons, which I'm not going to go into, diclofenac and COXIBs, they've been pitched head-to-head reasonable number of times, 33 trials, 62,000 patients and 91,000 person years. And in that time, 773 major vascular events have occurred. And the rate ratio is very close to 1.03 for diclofenac versus COXIBs, with a confidence interval reasonably narrow around 1. For other reasons, COXIBs have been compared head-to-head against placebo, and quite a few trials, 184 trials, mostly small and short-term. So even though there's many more trials, there's actually fewer person years, 52,000 person years in total, nearly 500 major vascular events. And when pitched directly against placebo, the relative risk for COXIBs versus placebo was significant excess, 1.4, with a confidence interval ranging from 1.1 to 1.7. So what does this mean? It means that if diclofenac had never, ever been tested directly against placebo, this is all you really have to go on. An indirect assessment of diclofenac versus placebo, that would be a relative risk of 1.41. And if you had a confidence interval around that, and we did in the paper, it would be highly significant. Now, diclofenac has been tested against placebo, but you might be shocked to see that there's almost no evidence. So 26 trials, 5,000 patients, 900 person years, 3 major vascular events. And it's 2 versus 1, if you're interested. So the direct evidence for diclofenac versus placebo can't tell you anything. And the indirect evidence is really what you have to go on. Okay, so just got 2 more slides. I've given you some what I think are really beautiful examples of meta-analyses that Colin's led many of, most of them, in fact, over the last 30 years. And these have had enormous impact on policy and practice. In the mid-1990s, changes in the way fibrinolytic therapy and aspirin are used. In the 2000s, further work on aspirin, demonstrating that it was correct, that it wasn't licensed for use in primary prevention, at least in the UK. For alteplase and acute ischemic stroke, Colin was on the expert committee of the MHRA. For the review of NSAIDs by the EMA, the MHRA, and the FDA, Colin gave evidence to several of those committees. We mentioned it for the manager of dyslipidemias. Colin co-chaired the committee in 2019 and was on the committee for the 2 previous reports as well. And then in the US, pretty much every single society you can imagine the guideline on the management of blood cholesterol cited CTT as the main source of evidence. So in summary, ChatGPT is entirely correct, I think. Meta-analyses can indeed be beautiful with regard to their scientific rigor, visual appeal, simplicity, impact, and in particular, I think their ability to reveal insights about treatment effects that you just won't see, even with the best single trial. Colin's meta-analyses over more than 30 years now have produced some remarkable insights, I think, in how to prevent and treat cardiovascular diseases, the findings that have been universally accepted and changed the way millions of people worldwide are treated. And for my part, Colin, as you know, it's been a pleasure to been a part of that work for the last 20 years at least, and I've had the opportunity to work with you on some of these major projects. Now, I still had my browser open when I finished my presentation, so I went back to ChatGPT. I said, which of Colin Baigent's meta-analyses do you think is most beautiful? And I'm quite pleased it came up with a good answer. So Colin Baigent's been involved in several impactful meta-analyses, especially in the field of CVD. One of the most renowned and widely cited was the work on cholesterol. The combination of methodological excellence, impactful findings, and clear visual presentation as a standout example of the beauty and rigorous scientific research. And I really, could not agree more. And that was supposed to be a perfect segue to the next presentation, which was going to be from Kirsty on CTT, but I think it might, well, I'm not sure what the order is now. Anyway, so Colin, thank you very much. And
Rory asked me to talk on size matters. Is there anybody in this room who doesn't think size matters? I've got to persuade you all that size matters. That's my job. It's, I don't know what to say. Anyway, well, okay, size matters. That's the answer. And some obvious points that you need all the main trial results to avoid undue emphasis on particular studies. You need to avoid unduly data-dependent emphasis on particular subgroups. You can look at subgroups and you can say this is different, as he did when he picked out the intracerebral hemorrhages at the beginning of the blockbuster trials in stroke. Well, that's actually not data dependent at all. It was the main thing people were worried about. But you just got to have big numbers, and then you've got to make sure you don't get too biased. And I've told that magnesium story so many times; it's been told. Anyway, okay, Colin, 33 years. I'll go back a long time. It was first 1980s is medication and education. First, he has a renal transplant, which seemed to work anyway. And then he did a maths degree. I think he got a first-class result. I'm not sure. Then he did a medical degree. But that renal transplant, can renal transplant save a life? Yeah, that renal transplant saved thousands of lives. So that must be one of the most successful renal transplants of all time in terms of medical statistics. Okay, then from 1991 until today or yesterday or something, he worked in what was the CTSU, now is, I don't know whether it's called NAFO Department of Population Health or Octopop. And then I just pick out some particular meta-analyses that Colin worked on. He worked on the antiplatelet treatment trialists, which then became later the antithrombotic treatment trialists reports, particularly 1994-2002. Worked on the cholesterol treatment trialist one, which Jonathan mentioned both of those. That's why I wish I'd gone before him. But particularly as interest was focusing on cholesterol, the epidemiology of cholesterol, getting the epidemiology right, allowing for regression dilution in the epidemiology, which is why all those lines had the slope they did, and putting the trials together. Basically cholesterol was really in the air, and particularly in this department, we were also paranoid about cholesterol-lowering drugs being undervalued. And Rory had been struggling for years to get, well, Rory, Tony, me, but Rory then took it forward. He'd been struggling for years to get the heart protection study going. And of course, Colin was working here in those early years, the early 1990s, and was interested in renal disease. You get interested in diseases, you got them yourself, and was looking at the high heart disease rates in kidney disease. But it really wasn't at all obvious. It's okay to say in retrospect, yes, cholesterol lowering matters for renal disease. But at the time, the actual abnormalities in renal disease hearts were enormous thickening. It didn't look like sort of pulmonary atherosclerosis at all. So it really wasn't clear whether statins would be of any relevance, and most renal doctors thought they wouldn't be. So anyway, so he decided that he was going to do a seriously large trial in renal disease, study of heart and renal protection, which started planning it in 1995, and it produced its first main report in 2011. But it had various side effects. Actually, I first met Colin in my kids' piano lessons in Jericho, and they were very successful piano lessons in that I met Colin, and Colin finished up working here. But they were very unsuccessful in terms of getting the kids to actually play the piano or to have any interest in the piano, whatever. So my piano finished up with Martin Landre's kids. And the other main thing about Sharp was that it actually got Martin Landre here, and therefore, of course, was indirectly a cause of the recovery trial, which was the best trial during COVID. And it basically founded renal studies in this department. Nobody else was really thinking of concentrating on renal disease. We were concentrating on stroke, pulmonary embolus, heart disease particularly, but not really renal disease. And it was Colin that got this big shift of emphasis, which has just been very successful. And of course, recently the EMPA kidney trial. So these are sort of consequences of his sort of early strategic decisions. I'll skip over the next two slides because Jonathan's already shown them. One is, well, they're just a couple of CTT slides. One is this is just looking at the different trials of cholesterol lowering drugs. And of course, various trials had very different sized LDL reductions. And since the idea is that reducing LDL is what's going to be protective, a trial which was producing up at the top right, say that's another point. This one up at the top right, which is producing nearly a 2 millimole reduction, is obviously going to be more effective as treatment. And these things down here, they're producing about a 0.5 millimole reduction. And then how do you do a meta-analysis? And so that's why all the meta-analyses Jonathan put up are meta-analyses of the relative risk per 1 millimole reduction. And that obviously led on to the next set of trials. So these are the trials of statin versus no statin, or cholesterol lowering versus no cholesterol lowering. And then there were the trials of standard cholesterol lowering versus more intensive cholesterol lowering. Actually, some of them with regimes we wouldn't use now. But anyway, they produced, so whereas the average reduction in those trials I've just showed you was 1 millimole, the average extra reduction in the trials of intensive versus standard statin regimens was about 0.5 millimole. And whereas these got a 22% risk reduction per millimole, these got a 15% risk reduction per millimole. But if you put them together, you might estimate that if you got a 2 millimole reduction, which can be done now with modern regimens, then you might finish up with, well, 34% reduction of a third, if you could take things down 1.5 and maybe halving the risk with a hypothetical 2 millimole reduction. That was hypothetical in those days, but it's not hypothetical anymore. So this is a predicted thing. If it's relative risk 0.78 with 1 millimole, then 0.78 times 0.78 takes you down to 0.6, so a 40% reduction. And that's what was predicted from putting together the trials of statin versus no statin, and then more statin versus less statin. And it's turned out to be a correct prediction. So that came out of just the detailed meta-analyses. It's a nice story. Okay, now this is Colin. I put it up for two reasons. One, in case nobody knows him, but the other is also that, in those days, Richard Doll had absolutely the flashiest ties. This is one of the least flashy of Richard Doll's ties. But Colin definitely had the best shirts in the department, and he always has had. Okay, so first renal transplant, maths degree, medical degree, worked in CTSU. I want to just pick out now this one meta-analysis. I want to pick out these anti-thrombotic trialists, treatment trialist reports. Finished up over 100, well over 100,000 people in them, and they were bloody phenomenal. I mean, I looked up the paper. In fact, one reason I finished up late for this talk is because I finished up digging out the, I think it was the 1994 paper, yeah, and reading through it. And in those days, papers could be sort of narratives. Do you know, they've got word limits on papers nowadays. They've got word limits on abstracts. That abstract had 750 words in it, and the actual text of the paper was something like 11,500 words with 11 figures, all in printed BMJ. I mean, they don't build them like that anymore. Now you've got to do everything according to guidelines. But it's, and actually, as a result, it does tell the story of what the meta-analyses are really doing. It really sort of explains, because still it was considered, meta-analyses were considered relatively novel. And you have to not only give the results, but also really explain why meta-analyses were appropriate and why this particular meta-analysis was trustworthy. So it's rather a long narrative. So it's a rather curious paper. It didn't get cited as much as the 2002 paper. I mean, that's still being cited. The 1994 paper, according to Google citation rates, which are about 50% higher than Scopus citation rates, says about 55,000 citations for the 1994, 9,000 for the 2002 one. Okay, but coming back to these antiplatelets, since 1994, it was a 3-part paper. They said we can't publish, that would have been more than 20,000 words in total, the 3 parts put together. Part 1 alone, it's 242, that's actually been 142, I think, round to 12,000 words, 242 is trials in all 3 papers. There's about 12,000 words, including the abstract. With 433 references, you only have 30 references nowadays. I think it's somebody who said for electronic supplementary material, but in those days it wasn't available. And it was a fairly heroic effort. And although we knew that these things were needed, it was actually working, just a whole team working together to make it happen. That was eventually successful. And these are the sort of the results. I mean, Jonathan showed you them, so I won't go over them again. So this is now from 2002 version. 20,000 patients with previous MI, 20,000 with acute MI, 20,000 with previous stroke TCI, 40,000 with acute stroke, and various other vascular conditions. And the main outcome was vascular events, up in the tens of thousands. And, Jonathan said treating millions of people, treating tens of millions of people, affecting the treatment of tens of millions of people, affecting in doing it for the better. Colin also took on the old Colin Baigent ISIS-2 result. So, these are just a graphical illustration, multicolored illustration of what I just said. So you can see the benefit, antithrombotic versus control in people with previous MI, it's a few years of treatment, acute MI, that's 1 month of treatment, previous stroke or TIA, that's a few years of treatment, acute stroke, that's 1 month of treatment, and various other high-risk groups, unstable angina and so on. Okay, so that was very nice. That's the 2002. Then he also went back to the old 1988 ISIS-2 result and did 10-year follow-up of that, showing that those early gains are not transient. The lines just ran parallel from the end of that first month when treatment stopped. Okay, got out of hospital alive. Do they stay alive? Yes. The lines just ran absolutely beautifully parallel for the next 10 years. So that answered a question which people were asking, are you just producing temporary? What are you actually giving them? And the answer is, 10 good years of life on average. That's 10 quality adjusted years of life for the health economists. And the other thing in that 2002 paper, it did say that, look, okay, we can't see any real differences between these different antiplatelet regimes, but that doesn't mean there isn't anything. There could be differences. They're not necessarily all going to be equivalent. But if you're going to actually sort out difference between them, the differences are going to be small. You're going to need to randomize tens of thousands of patients. So just basically saying, you can't really tell. So anyway, Jiangming and Yixin Jiang and various others decided they were going to randomize tens of thousands of patients. And so they did. There's the ISIS-2 result, which you just saw, where placebo versus aspirin was taking the 1 month mortality down from 14% down to 10%. And then the Chinese stroke trial on 46,000 patients then said, if we look at, this is now reinfarction or death, then what's the risk? Based on 46,000 patients, that further change from 10% down to 9% as you go from single antiplatelet plus placebo into the same antiplatelet plus clopidogrel So double antiplatelet versus single antiplatelet placebo controlled, yes. You make things a bit more effective as antiplatelet, and you do get a small further gain, which is real because the numbers are big. That's a 0.01 difference. So it's just, but we're getting to the point where there's questions that we want to answer. It's just simply not practical to answer. I don't know how to get the politics right of getting the appropriate numbers randomized. It's obviously appropriate socially from society's point of view, but it's not at all obvious how to make it happen. We've done it to a certain extent with meta-analyses. We've done this doing some big trials. We haven't achieved the sort of culture of really large-scale randomization that we'd want. We've advertised how useful it will be and helped establish it, but anyway. And then this is a penultimate thing. This is what's happening now at the moment when people are saying that, you know, there's calls to the WHO to make a sort of mid-century target of halving premature death by mid-century. Well, if they're going to do that, I mean, there's only so much you can do by actually disease prevention. You've got to actually get treatment, and you've got to treat people. Well, you can't treat everybody around the world with all these drugs, you know, with primary prevention. Not there's disadvantages in primary prevention as well, especially with something that tends to increase bleeding. We do have platelets for a reason. But if you combine things, aspirin versus nothing produces something like 7% annual recurrence risk down to 5% per year. Aspirin plus blood pressure lowering, sort of standard generic stuff, 5% a year down to 3% a year. Add a statin into that, take 3% a year down to 2% a year. So putting all these things through a network, as is now fashionable to call them, daily use of 3 or 4 generic drugs could prevent 2/3 the risk of stroke or MI recurrence, at least for several years. That's the recurrence rate, which is being reduced. And if this is going to be done, I mean, you know, non-communicable disease is the main cause of death worldwide. And there's plenty of places in the world where there's enough medical care at least to recognize that somebody's had some sort of an event. And this could be used. And the question is how to actually make this happen. What are the practical ways of making it happen? The meta-analyses have laid the foundation. How can it actually happen? Basically, you know, again, summarizes what I just said, with low-cost combination pills, a main strategy is secondary prevention, or some sort of high-risk disease. You know, is diabetes treatment of diabetes secondary prevention or primary? But some sort of treatment of patients with disease could work globally, wherever in the world the diagnosis of or occlusive stroke can happen. And the 10-year recurrence risk in otherwise healthy people might be reduced from about a half without treatment down to maybe about a 1/6, or anyway down to about a 1/4, but an absolute gain that is worth having. I think this treatment of high risk, though, one's got to be quite careful about it, because if you're not careful, the people that are at high risk, at highest risk, are the people who are 90. You know, they're old. Being 90 is a huge risk factor, and yet you're not going to gain much by actually protecting people aged 90. And so when we talk about high risk, I think we've got to be talking about you're at high risk of having an event in the next few years that will knock off several quality adjusted life years. So this slogan, treat high risk, not high cholesterol, treat high risk, not high blood pressure, it's got to be qualified a bit. It's high risk of losing something really worthwhile from events that happen over the next few years. And that's what you need to answer if you want to say the question, should we be starting treatment now or 5 years from now? And I can't think of any snappy way of saying that. In treat high risk, not high cholesterol, treat high risk, not high blood pressure. That's so easy to say, but I don't know how to actually get this thing about, you know, which avoids saying that we should be treating the 90-year-olds and ignoring the 60-year-olds, which isn't what we want to say. Okay, now last one line. What about primary prevention? I think this is less obvious. And in the 2004 paper, Colin and I spent ages and ages sitting around, 2002 paper, Colin and I spent ages and ages sitting together. What should we say? What should, you know, because it does reduce the event rates in primary prevention, but you also have side effects, and you're medicalizing lots and lots of people who wouldn't otherwise be medicalized. That's not true if you're doing secondary prevention. They've come to you. If you're going to go out and do primary prevention, you're medicalizing the unmedicalized. You've got the side effects. And eventually, I think we concluded in a vague way that it's the same thing about vaccine safety. You can't just ask of vaccines that they will do more good than harm. That's not enough. You actually need, you've got to have the side effects, just even rare side effects aren't really acceptable. And, you know, to get cerebral hemorrhage as a side effect. And so the last line in that paper was that, you know, basically primary prevention may well be inappropriate. And the BMJ editors did a wonderful job editing it. It was a big paper and they edited it. And obviously inappropriate cannot be what the authors meant. And so they changed it to appropriate. So the printed version of that paper ends with the exact opposite of the conclusion that we had decided on. So anyway, Colin, I hope you remember that episode. Thanks.
Thank you very much, Rory. So I'm delighted to be here today. John and I actually joined the department a month apart, nearly 20 years ago, and it's such a pleasure to be able to present this on behalf of the team, I should say. So everybody knows what statins are, but I had to put this up because, of course, they were pioneered by the Japanese scientist Endo, who actually sadly died last week, having never actually got a Nobel Prize for it, I don't believe. But little could he know how much his work would transform the world. We all know that they're HMG-CoAs reductase inhibitors that reduce LDL cholesterol. And the first statin came online in 1987, so quite some time ago. And depending on the type and dose of statin, we all know they can reduce your LDL cholesterol by 20 to 60%. And there was a whole raft of statin trials took off in the late 80s and 1990s, in both primary and secondary prevention. And we all know just how impactful those results were. But what some people may not remember is that early in their development, there were actually real lingering concerns that statins actually and lowering cholesterol might increase particular cancers and or non-vascular mortality. And so the CTT collaboration, cholesterol treatment trials collaboration, was really set up with this in mind. It was actually founded in 1993, and just to flag, that was prior to publication of the really first pivotal statin trial 4S, which was published in 1994, because it was already recognised that any one individual trial, even a really good large powered one, may not have sufficient statistical power to look at effects in particular kinds of patient or at mortality. And the real strength of CTT, and the reason it takes so very long, is it's an individual participant data meta-analysis as opposed to summary tabular meta-analysis. And so you really can look at effects in particular kinds of people. And when it was set up, CTT's main aim was to look at major vascular outcomes, mortality and cancer. And unusually perhaps for the time, but very far-sighted, it published a protocol in 1995. And at that point, to get into CTT, you obviously had to be a randomized trial. The principal effects had to be modifying blood lipids. They had to be unconfounded, recruiting at least 1,000 participants, so pretty large, and a scheduled study treatment of at least 2 years, so pretty long. And as new trials were published and joined the CTT collaboration, the IPT dataset grew sequentially over time. And it now encompasses about 28 trials, actually. It depends which trials you pull in, but about 175,000 participants. And there's been a whole raft of publications, which John and Richard have already alluded to, and it's really been game-changing. And I'm not going to spend any time on the slide because I think you've seen it 2 ways already, but statin therapy is amazingly effective in a very wide range of patients, even those who start with a low baseline LDL cholesterol. But I alluded earlier to there have been concerns about effects on non-vascular mortality, and here you can see very nicely that worry was not borne out in the CTT analyses, and neither were the worries about cancer, either overall or at any specific site. So you think this was surely a slam dunk. You've got an amazingly effective drug, no obvious concerns. And statins did indeed completely transform the management of CVD. Certainly when I was a medical student, they were a very sort of topical thing. And they're now one of the most widely, if not the most widely prescribed drug worldwide. And of course, they're now generic, so they're highly affordable, which when you consider the rising burden of CVD in sort of less developed areas, that's extremely pertinent. Of course, there's all sorts of new sort of trendy drugs coming online, but these really are incredibly cost effective. However, unfortunately, over recent years, there's been widespread concerns about potential statin side effects. And I think really everyone would acknowledge that this has been fueled horribly by inaccurate media reports. So despite statins potentially being one of the most highly studied drugs in the world with an amazing evidence base, perhaps rivaled by aspirin, there's actually a lot of uncertainty, not just in patients, but also doctors. And it's been shown that this has led to people refusing to start a statin when they really could benefit from it or stopping it. And that actually is impacting morbidity and mortality, and it's a really big health concern. So we'd recognised this back in 2015, 2016, and so we decided to extend the pre-existing CTT dataset by going not just after vascular outcomes, mortality and cancer, but actually all adverse events or events that happened during the trials. And we published our protocol again prospectively in 2016. Quite a tricky protocol to write because we weren't quite sure what we were going to get. But we also asked for reasons for stopping study treatment, co-medication, laboratory results, and obviously lipids and demographics. And we really set out to finally ascertain all statin effects reliably. So not just assessing potentially adverse effects being billed as side effects, but also there's been some thought that maybe statins may have additional beneficial effects. And by doing this, we'd really be able to hopefully definitively answer it for the first time. Going into what we actually got was a bit more than we expected. We got data from 23 double-blind statin trials and 5 open-label trials. And a difference with this project from the early CTT projects, where essentially people often just shared their data with you through email and a spreadsheet or something like that. And we were in a completely different ballgame of how to get legal data sharing agreements, which was extremely complicated. And also a lot of the big pharmaceutical companies have moved to online access portals, which sound great, actually quite tricky for reasons I won't go into in this talk. But we asked for protocols, SAPs, case report forms, clinical study reports and data sets. And it was really a sort of almost forensic exercise to work out what each trial had collected and to make sure we weren't missing any data, because we were extremely keen to make sure we weren't biasedly missing anything that had been collected. And as I've said, the use of data sharing platforms also meant we had to adopt a 2-stage meta-analysis approach, and we got a whopping amount of data, 845 data sets, more than 38 million records, 30,000 study variables, 1.2 million adverse events. And we are actually a small team. They're here today. We're only about 10 people, so this was quite thought-provoking. Many of us work on other projects as well. And furthermore, it was quite messy, this data. You know, they weren't all collected nicely in the same way. There were actually different languages used to code events, for example. So that was quite a challenge. So we sort of thought, how do we handle this then? Well, the first thought was probably to run to the hills, but we did what British people do. We kept calm, we carried on, buoyed up with plenty of tea and coffee and the odd pub trip. And actually what we did was we decided that we were going to have to do something different for this project compared to how CTT had been done previously and create new methods. And we really adopted a 2-pronged approach. And I'm not going to go into this in detail, but we used something called CDISC STTM, which is a standard way to tabulate data. Lots of our trials now use it, but it allows you to categorize everything consistently so everyone in the team knew what somebody else was talking about with respect to a certain variable. But we didn't sort of doggedly follow it. We just took a pragmatic approach. And we also recoded all the adverse event data into one dictionary. And we used Medro, which is widely used nowadays. And that was really a considerable amount of work. And if you're interested, we actually have published our methods. And I'm particularly proud of this paper myself, A, because we did publish our methods, but B, I think it'll give you an idea just how hard the team worked to get to the point of having results. So initially, we've sort of had a sort of stepwise approach to what we're going to look at, because given the huge amount of data, we couldn't just do everything in one go. And so we focused on muscle outcomes initially, because this is really the bugbear of people on statins. And of course, as soon as you're warned that you may get muscle symptoms in statin therapy, guess what? You know, lots of people do. And it was already known that statin therapy can cause myopathy, but there's a distinction here. Myopathy, or in its more severe form, rhabdomyolysis, is muscle symptoms plus evidence of significant biochemical damage, classically measured by creatine kinase. And in its severe form like that, it is rare, less than 1/10,000 per year in standard statin doses. But what wasn't clear is what about the less severe muscle symptoms, where there isn't necessarily a CK to go alongside it. And there's been so much published in the media about this. And it's actually now been given its own title, SAMS, statin-associated muscle symptoms. And those people who work in the lipid clinic, like David, my colleague, and Louise, they'll tell you this is quite a large proportion of people rocking up. But of course, we all know that a lot of this sort of cause of concern has come out of non-randomized observational data. And of course, they're prone to bias and confounding. And here CTT could really come into its own, because we have randomized studies and most of them were double blind. So off we went. And this is the overall headline results. You can see the huge amount of data we had. We really were in a great position to answer this reliably. And you can see there was just a risk ratio of 1.03 overall for all these components of any muscle pain or weakness. So really very small indeed. And it seemed that actually these effects were most manifest if you are going to get muscle symptoms within the first year. You can see there in the first year, the rate ratio is 1.07, but after the first year, it drops to 0.99. And so again, small effects mostly in the first year. And if you then sort of try and think about this further, well, what's that really mean? What portion of symptoms of muscle symptoms are due to statin? I've just shown you the rate ratio of 1.07, but what that really sort of figures out as is that in 14 out of 15, so over 90% of people who get muscle symptoms while taking a statin, it's not actually due to statin therapy. So we were able to get at, how much of symptoms were attributable to statin therapy with our analyses, and this was extremely powerful. And just to summarize all those findings there, I should have said on my earlier slide, one big thing that came out of these analyses is, guess what? Muscle symptoms are really common. If you ask me right now if I've got muscle pain, I can find it for you. But it's about a quarter of people will get symptoms, whether they're on a statin or not. But there's less than 1% excess risk in those allocated statin therapy. And I've mentioned the other findings here, small excess in the first year, little risk after year 1. But what you need to remember is that when you're taking a statin, the benefits keep accruing. So while the muscle symptoms, if you do get them, are likely to occur in the first year and then abate, the cardiovascular benefits are keeping to build. And so that's really important to remember. And there's a slightly higher risk with higher intensity statins that I haven't shown here today in the interest of time, but you can find out more through our links here. And this was presented by Colin ESC in 2022. So we then moved on to our next pre-specified in our 2016 protocol outcome. A big topic was, do statins cause diabetes? Now, David, my colleague who worked with closely on this particular paper, and his when he'd previously done a summary meta-analysis showing that actually statins probably do increase the risk of new onset diabetes by about 10% compared with placebo or usual care, and that more intensive statin regimens will produce a further 10% relative increase in risk. But it still didn't tell us what type of people might be at particularly high risk of developing diabetes on statins, the timing of this risk. And actually, for those with diabetes already, there was really nothing much out there about what that did to their glycemic control. So this was our next outcome we went after, and we used 3 sources of data, not just reports of people developing diabetes or having a complication related to diabetes, but also co-medication. And particular thanks to the team, I'm looking at Kelly in the audience, had to go through all the co-medication and code it drugs that looked related to diabetes to a drug dictionary, because of course actually diabetes drugs like metformin or insulin are pretty specific. So in this case we could use them as a surrogate. So even if we didn't have a report of developed diabetes, if we saw that commenced insulin, it was fair to assume that. And we also went through all the biochemistry, which is a complete minefield. Obviously, we have lots of different labs and reference ranges. HbA1c works as a percent, so that's a bit easier, but obviously glucose doesn't, and whether it was fasting or not and so forth was quite challenging. And here are the results that were just published in March in Lancet Diabetes and Endocrinology. And you can see that for lower moderate intensity statin therapy, there's a rate ratio of 1.10, so about 10% proportional increase. And that risk is higher for higher intensity statin therapy. But one thing I would say about, without going into too much detail here, is that those results were really dominated by one trial in particular that proactively collected HbA1c much more frequently. So really the absolute effects are sort of driven, if you like, by the proportion of people having a biochemical assessment rather than the proportional effects. So here you can see that certainly the results are broadly in line with what we thought we might see earlier, but in much more detail and split down by how those diabetes outcomes were determined. We were able to look at actual glycemia in the trials. This was data was a bit more limited, not everyone collected it. And of course, HbA1c only came online really as a diagnostic marker many years after some of the statin trials had been incepted. But you can see that increases are really tiny. Mean glucose increased by 0.04 millimoles per litre for any type of intensity of statins, and HbA1c by 0.06%. And we also looked to see what would happen for absolute excess rates of diabetes subdivided by statin intensity in quartiles of glycemia and quartiles of 5-year predicted risk. And it might be a little tricky to see, but the blue is the placebo rate and red is the absolute excess. And you can see that for those people who did have a measure of baseline glycemia, approximately 2/3 of cases of new onset diabetes were in people who were already in the top quarter of the baseline distribution. And you can see that quite clearly with the red bars furthest to the right. And so what does this all mean? Well, we did some modelling actually using UK Biobank because we couldn't easily do this in our own data. But this is what's happening really. So there's a tiny increase in glycemia. You're sort of right shifting everyone upwards, if you like. But what that means is even a tiny shift like that can actually make quite a difference to the number of people who are actually finally crossing the threshold to develop diabetes. So really, these are people who are on the path and they sort of got nudged over the finish line. And then we also looked at the effect on worsening glycemia in those who already had diabetes at baseline. And you can see the results largely mirrored the results we saw for new onset diabetes. So we've been like corroborating that this effect is working the way we thought it was. So I've summarised all that there. I'm not going to read every line out in the interest of time. But one thing I would say is just to highlight the last bullet, because a lot of people have been saying, well, diabetes is really bad. And what's this mean? And you're at risk of having a cardiovascular event if you get diabetes. But just to really put home that any theoretical adverse effect of statins that might arise from the sort of dinky increases in glycemia that we saw, or indeed actually any other mechanism, are already accounted for in the overall reduction in cardiovascular risk seen with statin therapy that have already been reported. So the benefits do still hugely outweigh any risks. And this is something we've worked quite hard to try and get across. So we haven't stopped there. And unfortunately, if this meeting had been about 3 months' time, I could have shown you something which I think is probably going to be the paper of my career. It's what we call the label paper. So when you are a doctor or a patient and you open the product insert for a drug, I mean, it's surprising anyone ever takes anything, frankly, because it looks so downright scary. And if you look at the summary of product characteristics under undesirable effects across statin labels, there are over 150 event types listed as something bad that might happen to you in statin therapy. But what's really interesting is you dig into, well, how did that stuff get there? I mean, when I was a medical student, it didn't occur to me to question how the BNF made itself up. But I do question it now. I've been here for 20 years. And actually, it's pretty shoddy. Often terms are just added on non-randomized evidence. And there was a report by the MHRA in 2009, which did exactly this. They started off really well, talking about the randomized trials. And then they went, ooh, but we've seen a few cases of this, and it might be due to it, so we're going to put it in the label. And of course, unfortunately, with litigation and so forth, this is driving we've warned people, we're going to put it in the label. But, does that help inform people? I would say arguably not. And so people just get scared off taking something that could really, really help them. So this work is actually, we've produced our analyses, we've shared it with the collaboration. I'm afraid it's too premature to share it with you. But please do watch this space, because it's going to be a paper that basically all figures are just one massive forest plot of all these outcomes. And we're very hopeful that this will change the way regulators think, not just about statin labelling, but labelling more generally. And I think is going to be a huge public health impact of this project. And we're actually going to look at all the other things that aren't even in labels. So for instance, macular degeneration, the list goes on. And actually, both these comparisons are going to be very interesting statistically, because, of course, we're doing so many comparisons. So John and Enty, I'm pleased to see today, who was a DPhil student with us, have looked into this, and it formed the basis of Enty's DPhil. And so we are accounting for multiple hypothesis testing, which I won't go into in detail today, but we can help deal with that by controlling for the false discovery rate. And then, of course, we can look in hemorrhagic stroke in more detail and things like peripheral arterial disease, which hasn't been reported substantially for statins before. So I was asked at the beginning of this talk to talk about, are statins safe? I was quite tempted to do what Martin Landry did when he presented the SHARP results in Denver, which was, you may remember, Martin, you stood up and went, they're safe and they work. And then I could have just sat down again, but I'd say a little bit more. But hopefully I've proven to you that the proven benefits of statin therapy hugely outweigh the risks. But I just also want to say, I think as scientists and researchers, something the communications team here has really taught me and helped with is it's really important to get that message across to a wide audience. It's wonderful to have a Lancet paper, but if half the public don't understand what you're talking about and you're not seen as the word, that's really difficult. So, you know, I think as a department and team, we work hard not to, you know, against fake news and misinformation. And thank you to the comms team for supporting us with patient and public engagement. But I'm pleased to say that I think the message is beginning to get through. As you know, Father's Day was last Sunday. My 13-year-old decided to make a badge for her dad. And I just had to chuckle when she pinned onto him. So Dave is 51. He's not particularly fat, hypertensive. Hasn't got diabetes, but he got his lipids taken and they said, do you think you want to go on statin? He said, I think I do. Anyway, the girls found this very amusing and I thought it was going to say like #1 dad or top dad, but official statin taker. So, and that was entirely unprompted by me, I should say. So there we go. So finally, closing with some acknowledgements. CTT success, like all the projects being discussed here today, is due to collaborative effort. It's never one person. And I know that's something Colin feels strongly about. So obviously, I've got some credits here. But of course, the person really to acknowledge today is Colin. And I've got this nice picture I found of him here. But that's not the whole story for this picture. No. No wonder he was looking cheerful. So I particularly like that picture. So obviously, Colin, thank you for your leadership, expertise and mentorship. Obviously, Richard, Pito and others blazed the way with IPD meta-analysis, but I think everyone agree that you are a founding father of them too, and your work's been very impactful. But on the note of founding fathers, I'm probably the only person in the audience who's had this sheer embarrassment in my career of writing an email to Colin that started, "Hello, Dad." Not the father figure he was hoping to be. So thank you very much, Colin. I'm indebted to you personally for putting up with me all these years.
Yes, so here we go. It's been quite a ride, and my talk is going to be very different. I'm just a clinician, and I rely on Colin to sort the numbers out. And that goes back a very long way to the antithrombotic trialists, when we worked very hard to gather the trials and get the data to Oxford. And so I was very grateful that all I had to do was the diplomacy. But when we got to thrombolysis, I had to call in the cavalry again in the shape of Colin, and I'll explain how that worked. So first of all, a bit of context. So stroke is not like heart attacks. It's more than one disease. It's a big disease globally, 12 million a year, lots of stroke deaths, lots of disability. And it's a disease of the elderly. About a third occur in people aged over 80. And as a clinician, the trouble is that strokes range in severity from something that's trivial. One of the mildest strokes I ever saw was a man whose stroke occurred while he was trying to do the clasp on his lunchbox, and the only thing he couldn't do was move his fingers in a sensitive way. And he'd had a stroke. He got better, and at the other end of the spectrum, there are severe ischemic strokes, big black hole in the brain, where you've a 95% chance of being dead or disabled 6 months later. So a huge range of severity. And this is one of the issues in trading risk and benefit. So in 1995, one of the big beasts, the Americans, did a trial of the design a drug, TPA. They're very excited about it. Never mind that streptokinase had been around for a long time, was an effective drug in heart attack, but the Americans regarded as a dirty drug, so that for stroke, TPA was to be tested. Because thrombolysis was very time dependent in heart attacks, it was thought that it was equally time dependent in stroke, but the approach was to say, okay, we're only going to recruit patients within 3 hours. We're not going to look at mild strokes, not going to look at severe strokes, and we're not going to look at older people. So this was a very focused trial. Unfortunately, the trial was lucky. It came out with a positive outcome, increased chances of being alive and independent at 3 months. But there was a hazard, as you've heard already, quite a significant hazard of nasty intracranial bleeding with TPA. But that was enough data in just 600 patients to license alteplase for these very selected patients within 3 hours. And because nobody had been randomized after 6 hours, the definition of time is brain was, if you can treat it within 3 hours, you're okay. And to their credit, this trial was a game changer. It persuaded the medical community that stroke was a medical emergency and we should just get on and deal with it. But what happened then, so NINDS was in 1995, other trials being run by Boehringer Ingelheim and trials run by Roche in America were running and being reported. So by 2000, as we were planning our own thrombolysis trial, this is what the data looked like. So about 3,000 patients, 8 trials, all done by industry or with industry support. And the net effect on mortality was looking a bit worrying. Now, so on the one hand, there was pretty reasonable evidence of a reduction in disability in survivors, but there was this hazard. And was this something we should worry about, or was this something that we needed to explore? And the bottom line was, if you're a stroke clinician and you're seeing patients and you start talking about the hazard at the front door, you don't have much time. The patient's just arrived. They're feeling in a very unsettled state because they've had a stroke and they may be disabled, and they can see ahead of them they may face a life of disability if they're not treated. So the discussions with the patients was, is my stroke bad enough to justify the risk of a fatal brain bleed? So for the low-risk individuals in the NINDS trial, the risk of a fatal brain bleed was about 1%. But we were thinking, well, what about all the patients aged over 80? What about frailer people, people at higher risk? And our estimate was that the risk of a fatal brain bleed in somebody like that might be 4%, so 1 in 25. So imagine talking to a patient and saying, Mrs. Smith, your husband faces a 1 in 25 chance of dying from the treatment, but that treatment might save him from disability. And so that gave rise to a series of questions for the IST3 trial, the third international stroke trial. Who benefits? Do people over 80 benefit? Do you benefit beyond 3 hours, or is it just 3 hours, your window for benefit? And what about the risk benefit in very mild strokes and very severe strokes? And exactly who gets bleeding in the brain? So we designed this trial, which in many ways was as controversial as ISIS-4, doing a large-scale trial when previous studies had suggested benefit. So we aimed for something small by the standards of CTSU, just 6,000 patients, a fairly heterogeneous group, an open trial within 6 hours of stroke onset at all ages. So we started a pilot trial in 2000, and that went rather badly. And you'll see why in a moment. So by 2007, 7 years later, the trial was still running. Our chairman, David Chadwick, respected neurologist, retired, And so the MRC said, you need a new chair. And so we fingered Colin, and mercifully he rode to the rescue. He'd bringing with him his fibrinolytic therapy trialist experience and a very clear understanding of how to think about early hazard. And he held my hand while we wrote to the MRC saying, please give us some more money to get to the end of the trial. And he was a very wise mentor through the process of getting to 2012 when the trial ended, despite the challenges. And these were the challenges. So we started our pilot study in quite a sort of careful way, because the world considered us not, because we were just aspirin trialists in Edinburgh. We weren't proper stroke doctors. And so we started rather cautiously to try and persuade the world that we knew what we were doing. And then the European Clinical Trials Directive came in, and we had to completely reorganize the trial and burden it with rather more in the way of monitoring and other things. So that slowed us down, and there's inflection in the recruitment graph. And just as we were getting going with some MRC funding, we hit the research governance framework and a number of other things that, again, really slowed us down. And so we had to revise our target down from 6,000 to 3,000 in order to produce something. So Colin got us there, and as you can see, his arrival as chair of the steering committee was associated with a speeding up of the recruitment, which was great. But we did face some fairly horrific critics. So John Marler, head of the NINDS, took Richard Lindley, my co-investigator, pinned him up against the wall with his two lapels and said, "You're killing patients in IST3." So this is, gives you a sense of the animosity we faced. And as we approached presenting our results to the world, Patrick Lydon, one of the co-authors of the NINDS trial, said that one thing the IST3 result cannot do is reaffirm or refute prior trials of thrombolytic therapy, which was a pretty extraordinary thing to say. So now I have to give it a credit. So clearly in 2010, there was an obvious case to do an individual patient data meta-analysis. I've been involved in the ATT, indirectly involved in the FTT. And so as the co-chief investigator, we said we have to get all the trials together, get individual patient data to try and resolve the clinical uncertainties that bothered us as clinicians, and also to handle the skepticism attached to this rather simple trial. And so Colin and I discussed how we would do it. Colin became the chair of the group, and it was very difficult to get this group of very important, self-important investigators to consider sharing their beautiful TPA, NINDS, drug company, highly monitored, perfectly conducted trials with this rather large and dirty trial run by a bunch of Brits, which they didn't like at all. And this is again where Colin's diplomacy skills were just terrific. And we got the big beast, and I think a huge thanks to the team, including Heather Halls and everyone else who helped make these big beasts feel welcome in Oxford. And Colin, I seem to remember, organised a dinner at Corpus Christi, which again, so there's some very high quality schmoozing going on. But the big beasts, as they entered the room for that 2011 meeting, Will Whiteley said it was like a bunch of lions walking in and looking at a carcass. The big beasts were not there to be nice. And so Colin and John had a lot of work to do. But he persuaded them that an SAP would clarify how it would be done. And John was very clear that it was not going to go into some sort of pool, but each trial would be handled separately within the meta-analysis, as he's already explained. And so that was published before the IST produced its results. Now, Rory was the chairman of the Data Monitoring Committee. And when we produced our results, he said, it's amazing that you ever managed to produce anything positive out of this trial, because this is what he'd been watching. The hazard. Now, there were a lot of bleeds in IST3, as we predicted, this is fatal and non-fatal, but the fatal intracerebral hemorrhage rate among the older patients was 4% as predicted. So serious and nasty bleeds. But this was the nice result, that the net effect at 6 months was that there was less disability. So this is a scale, 6 is dead, 5 is terrible, being bedbound and needing help for everything, and 0 is no disability. So receiving TPA within the first 6 hours of your stroke didn't increase your risk of dying by 6 months, but shifted your chances of having a bit less disability in a favourable direction. But that wasn't enough to really sort out the key questions about hazard and benefit. So IST3 more or less almost doubled the amount of data that was available, and importantly added 1,600 patients with who are aged over 80. So a useful amount of data to understand risks and benefit in the elderly. And I mean, essentially, there was no data by the time we reached our conclusions. So, well, the analyses confirmed that time is brain. Your chances of being alive with no or minimal symptoms by 3 months were highest if you were treated within the first hour or two, just as in myocardial infarction. There is a couple of golden hours at the beginning, and the benefit declines with time. But nobody at that stage was randomizing out here beyond 6 hours. And in fact, there are now patients out up to 24 hours who can be treated with intravenous thrombolysis with careful selection. But that's another story. Importantly, age and stroke severity didn't modify the slope of the relationship. Another very nice result is that among patients over 80, only 13% of whom without treatment had a good outcome. The proportional effects were similar, if possibly even slightly greater among older people. So that was really nice news. And that led to the extension of the label for TPA to patients over 80. Severity is measured with this scale. 0 to 4 is very mild, 22 is very severe. The proportional effects are similar across all strata. But as you can see, if you've had a very severe stroke, your chances of being alive with and free of disability match the epidemiology, about 3%. So what about the risk? Well, the harm, and this is again one of John's very beautiful slides, the proportional effects are not what you expected. People out there thought the risk of bleeding would be greatest if you were treated late. Not true. Would be greater if you were 80 or more. Not true. And the belief was that the bleeding was probably not affected by the severity of the stroke. Well, once you adjust for age and time, if you adjust for time but age and severity, then the absolute excess of bleeds doesn't really vary across time. If you model for the other two, delay and age, then severity is a key determinant. So very mild strokes are at low risk of bleeding, and severe strokes are at a higher risk of bleeding. And so this has helped in all sorts of ways to understand how to discuss things with patients. And nowadays we start to think about not treating some of the most severe patients and switching them immediately to palliative care. But that's a whole different story. So we need to move on to the conclusions. So this is the abstract of the 2014 publication, which summarizes, despite the absolute increased risk of early death from intracranial hemorrhage by about 2%, by 3 to 6 months, this risk is offset by an average absolute increase in disability-free survival of about 10% for patients within 3 hours and about 5% for patients treated up to 4.5 hours. But the reason for showing that conclusion is this. So these are the big beasts all round the table after Colin and John have presented the results. And you can see they're all smiling, they're all looking happy, and they were persuaded, as Colin had predicted they would be, by seeing the data. And I think that was a very, very satisfying moment when all of them are smiling and nobody's pinned up against the wall. So the clinical impact, as you've already heard, is clinical guidelines changed worldwide. Alteplase was added to the WHO essential medicines list. And most importantly, the usage of TPA for people with acute stroke has increased, especially among the elderly. I don't know how many people in the audience are aged over 80, but if there are, and you have a stroke, do consider having Alteplase if it's offered. And again, a huge thank you to all of the team at the Statistical Analysis Centre and the Secretariat who made it possible to get these folks together and to persuade them that they should share their data. So thank you very much.
Thank you. Thank you, Rory, for the introduction and for the kind invitation to be here today to celebrate Colin and his remarkable contributions to medical science. So to go back a little, just 40 years or so, soon after clarification of the molecular mechanism of action of aspirin as an antiplatelet agent, which happened around mid-70s, our lab developed analytical methods to measure directly thromboxane production, both in vivo and ex vivo, to replace platelet aggregation measurements that had given pretty controversial indications as to the dose of aspirin optimal for thrombosis prevention. And when Paola Patrignani joined the lab, we performed a series of studies to characterize the dose dependency of the inhibitory effect of aspirin on platelet thromboxane production. And as you can see, you can get complete suppression with a single dose of 100 milligram. And then we showed that you can obtain a similar maximum effect with a much lower dose, like 30 milligram given once daily, by virtue of this cumulative nature of thromboxane inhibition upon repeated daily dosing. We also showed that such a low dose of aspirin would spare prostacyclin production within the kidney, as reflected by urinary excretion of its stable hydrolysis product, and that when you stopped aspirin, the recovery of platelet COX-1 activity was pretty slow, time-dependent as a function of platelet turnover, and this would allow you to give a drug with a 20-minute half-life as a single daily administration, or possibly every other day, as they did in the Women's Health Study in the US. And because of this cumulative nature of platelet COX-1 inactivation, because of the irreversible nature of the acetylation process, the dose response curve is shifted to the left upon repeated daily dosing, whereby the drugs becomes 8-fold more potent as compared to single dosing, allowing a buffer of efficacy, biochemical efficacy, dealing with inter-individual variability in drug handling and drug response. And based on these findings, we predicted that any antithrombotic effect of the drug related to this particular mechanism of action would show two unusual characteristics: saturability at low doses, and the requirement for a single daily dose despite the very short half-life of the drug. So in contrast to this remarkable saturability of the antiplatelet effect at low doses, Gareth Fitzgerald, at about the same time, while working at Vanderbilt University in Nashville, described this different dose dependency for the inhibitory effect on prostacyclin production as reflected by the urinary excretion of its major metabolite, and showing that you require high analgesic doses of the drug, like 650 to 1300 milligram daily, to reach a maximal inhibitory effect, thereby providing a window of opportunity to select a platelet COX-1 selective regimen. And at about the same time or shortly after, these three people in Oxford, whom you are very familiar with, two are present in the room, designed a pivotal trial in the cardiovascular field, which changed the way in which we treat myocardial infarction. This was the second international study of infarct survival, or ISIS-2, that assessed in a random fashion with placebo-controlled the separate and combined effects of intravenous streptokinase, a thrombolytic, and a relatively low dose for the time of 160 milligram of aspirin, having 5-week vascular mortality as the primary endpoint. You have seen from Richard the results of aspirin versus placebo. This shows the complete picture of streptokinase on your left-hand side, reducing vascular mortality by about a quarter. Low-dose aspirin producing a similar benefit, and not unexpectedly, given the completely different mechanism of action of the two drugs, when the two were combined, in the lucky ones who got both active treatments versus the unlucky ones who got double placebo, the combined effect is additive in reducing vascular mortality by about 40%. Then came a flow of studies using aspirin at progressively lower doses in both coronary artery disease and ischemic heart disease, ischemic cerebrovascular disease. And then came the ATT meta-analysis, and Richard Pito has already shown you this slide of the benefits in 5 different categories of high-risk patients. And what I was interested in as a clinical pharmacologist was the apparent lack of relationship between the daily dose of aspirin used in different trials and the benefit of aspirin in reducing major vascular events. As you can see, when you look at trials using the lowest doses, the intermediate doses, or the high doses, there isn't much variability. If anything, there is a slight trend towards higher doses producing lesser benefits. And when I reasoned along those lines, Colin taught me that you should not read too much into these indirect comparisons. Luckily enough, today we have at least 2 big randomized clinical trials directly comparing an intermediate dose of 300, 325 versus a low dose of 75 to 100. And both trials, current to AZ7 and adaptable, have failed to demonstrate any dose effect relationship. So what I was interested in about these results of the ATT meta-analysis was that it showed one of the features that we had predicted would characterize the antithrombotic effect related to this particular mechanism of action, that is saturability at low doses, that reproduces saturability of the pharmacodynamic effect, possibly establishing a cause-effect relationship between inactivation of this particular platelet protein through acetylation of a single serine residue to a remarkable clinical effect. Then came the COXIBs, or selective COX-2 inhibitors, towards the end of the last century, drugs that were developed by several major drug companies The idea being that by selectively inhibiting the inducible isoform of cyclooxygenase, you could reproduce the traditional pharmacological effects of traditional NSAIDs that are largely COX-2 dependent and spare COX-1 activity in the gastrointestinal mucosa, where products of COX-1 activity like prostaglandin E2 play an important role in local cytoprotection of the integrity of the gastrointestinal mucosa. And in retrospect, this development was also an opportunity to test the importance, the clinical importance of vascular prostacyclin production, because at about the same time the first two COXIB were marketed, Gary Fitzgerald demonstrated that the biosynthesis of prostacyclin, a potent antiplatelet agent, endogenous antiplatelet agent, by the vessel wall, is largely driven by COX-2 activity. So this is the first large randomized clinical trial comparing the GI safety of a highly selective COX-2 inhibitor, rofecoxib, versus a traditional NSAID naproxen. And it shows that the underlying hypothesis was correct. A selective COX-2 inhibitor could reduce substantially by 50% the burden of GI toxicity, upper GI events over 9-month follow-up. However, in the same trial, the VIGOR trial, in about 8,000 patients with rheumatoid arthritis, they recorded 24 myocardial infarctions, which were distributed quite unevenly, 20 in those treated with rofecoxib and 4 in those treated with naproxen. Now, given that rofecoxib was the experimental treatment and naproxen was the control, I imagine that all of you would describe these effects as the rate of myocardial infarction being higher in those treated with rofecoxib than in those treated with naproxen. But if you read the New England Journal of Medicine paper, they say the rate of myocardial infarction was significantly lower in the naproxen group than in the rofecoxib group, 0.1% versus 0.4%. And not happy about doing this, they go on and slice these 24 myocardial infarctions. They haven't read anything about Richard Peter, about subgroup analysis. So they identify those who would be candidate for aspirin therapy and did not receive aspirin therapy, where the numbers were 8 versus 0. And the rest of the vast majority of the patients for whom aspirin was not indicated, 12 versus 4. And they go on to say that the difference in the rates of myocardial infarction between the rofecoxib and naproxen groups was not significant among the patients without indications for aspirin therapy. A secondary analysis, which reads more like a Wall Street analyst rather than a statistician. And they conclude that our results are consistent with the theory that naproxen has a coronary protective effect and rofecoxib doesn't because of its COX-2 selectivity. Now, it is not surprising that the authors of this paper wrote what they wrote. What is surprising is that the New England Journal of Medicine reviewers and editors allowed them to get away with it. So a few years later, September 2004, Merck decides to withdraw rofecoxib from the market. And they say that the company's decision, which is effective immediately, is based on new 3-year data from a prospective randomized placebo-controlled clinical trial, the approved adenomatous polyp prevention biopsy trial, where looking at major vascular events, they recorded these different Kaplan-Meier curves of the cumulative incidence of confirmed serious thrombotic events, which looks pretty interesting because apparently nothing happens during the first 18 months. And then you start seeing this divergence of the curves. And they go on to say that the increased relative risk became apparent after 18 months of treatment. During the first 18 months, event rates were similar in the two groups. And it sounds like written by a litigation lawyer rather than by a scientist, because 3 years later, they continue following these patients and they published these revised Kaplan-Meier curves, not in the New England, but in the Lancet. So 2005, the original publication, 2008, 3 years later, while they were dealing with a class action by patients who thought they had been damaged by Merck. And all of a sudden, there is no significant interaction between time and treatment effect. And the interpretation is that study data are compatible with an early increase in risk that persists for 1 year after stopping treatment, which is what you would expect if the mechanism of this increased risk of myocardial infarction is related to inhibition of prostacyclin biosynthesis. You would expect to see immediate consequence of this inactivation of an important mechanism of vascular thromboresistance. If you look at the authors of this paper, all of them are either Merck consultants or Merck employees and stock option, whatever. So what do you do with an 80% increase with this wide confidence interval that ranges between a 17% to a roughly threefold increase in risk? Well, as you heard from Jonathan, you need a meta-analysis of all the trials, and it really looks like mission impossible. And it's really due to Colin persistence and diplomacy that he was able to convince 5 different pharmaceutical companies to provide individual patient data from over 200,000 patients recruited in hundreds of randomized clinical trials of acoxib versus placebo or acoxib versus another traditional NSAID. And you have heard already some of the results from Jonathan. This meta-analysis of acoxib versus placebo demonstrated roughly 40% increase in risk of major vascular events, largely driven by a 75% increase in coronary events. It was apparently a mechanism-based class effect because you had consistency among different coxibs, and those with the largest amount of information showed identical rate ratios for celecoxib and rofecoxib, despite markedly different COX-2 selectivity. And then when we looked at the traditional NSAIDs, we found a statistically significant heterogeneity among ibuprofen and diclofenac, showing a similar cardiovascular phenotype as the coxibs, while in contrast, naproxen had this 0.93 with relatively wide 95% confidence interval, suggesting a neutral cardiovascular phenotype, certainly not providing convincing evidence for a cardioprotective effect of naproxen. And this kind of information had a remarkable impact on both regulatory action by FDA and EMA, as Jonathan has already alluded to, had an impact on the medical scientific community that uses these drugs, particularly in osteoarthritis in elderly patients. But it also provided people like me in the pharmacology community with perhaps the first evidence linking inhibition of prostacyclin production produced by the COX-2 activity of endothelial cells to a clinical readout represented by increased risk of coronary atherothrombosis, suggesting that when something happens, for example, a rupture or fissure of a coronary atherosclerotic plaque, having or not having this important mechanism of thromboresistance intact and not inhibited by one of these drugs does make a difference in the outcome and potential mortality. So Colin has been instrumental in teaching people like me to establish a link. I would like to think of a bridge over the gap between asking mechanistic questions and providing randomized clinical evidence to address these questions. So thank you, Colin, for a wonderful intellectual journey, which I hope will continue. Thank you.
Well, good afternoon, everybody. My name is David Wheeler. I'm a nephrologist and I currently work at University College London. And I actually know some of these guys from way back. And so I've been given the honour of chairing this afternoon's session. So thank you very much for having me. Colin, I've got a letter here. And the letter is dated the 7th of June, 1996. So 30 years or so ago. And it's addressed to you and it says, Colin, I am a consultant nephrologist based at the Queen Elizabeth Hospital in Birmingham and have an interest in abnormalities of lipid metabolism associated with renal disease. As you will be aware from recent correspondence from my colleague Joe Adu, I have been asked by the Renal Association to organise a working party to develop clinical trials of lipid-lowering drugs in patients with kidney disease. Now, Colin, as you will remember, I had not got a clue what I was doing. But fortunately, I met you and you helped me understand what trials were about and how to do trials. And through that early collaboration, I learned so much about conducting trials. And I want to personally thank you for all that you taught me over the many years that we have been collaborating. I think I had something of a clue because I did say, any study addressing these issues will clearly need to involve several centres in order to be sufficiently powered. So I think I did have a little bit of insight, although you might not have thought so. And then my request was your expertise in the planning of such trials would therefore be of great help to the group. So that was the start, one of the start of my my experience of clinical trials, and I thank you for that. And we'll perhaps come to some of the other conversations we had along the way. Now, at the time, I was working with a very promising PhD student called Martin Landry, who was working in the Department of Clinical Pharmacology at the Queen Elizabeth Hospital in Birmingham, where I was, and stood out to me as being an individual with incredible potential. And I remember very clearly one day, Martin, a conversation that went along the lines of, are you really commuting from Whitney to Birmingham every day to work? And I said, I've got this guy I've just met in Oxford called Colin Baigent, and I think you should meet him because I think there may be opportunities for you in Oxford. So here we are today talking about the SHARP study which grew out of this collaboration and these discussions. And as I say, for me, this was the beginning of a journey. And Colin, you were very much a crucial part of that journey. And I want to personally thank you for that today. Importantly, I want to introduce Martin, who's going to tell us about the study of heart and renal protection and how we pulled it together. Thank you very much, Martin.
Well, thank you very much. And Colin, I'm going to come back to some of that story a little later on, but I thought we'd do the science first and then deal with the entertainment later. At least we'll find it entertaining. So if I go the right way, I was given the title. Right. I was given the title starting at the sharp end, but actually we didn't start at the sharp end. We started some way further back than that. If these will advance, yes, there we go. And this is the timeline. I dug this out. All my slides, I should say, first of all, are in this format. Secondly, they're in this format because I didn't write any new slides, because I dug all my slides out of talks we gave back in the early 2000s to sort of illustrate some of what we were doing. There may be one or two exceptions. But when one thinks about clinical trials, there's the highlight, which is the announcement of the results in a big meeting that comes at the end. There is the excitement when somebody finally agrees to pay for that trial at the beginning and you manage to get the first patient in. But there is, in all the big and important trials that I've run, particularly in cardiovascular and renal disease, there is a long preamble of one kind or another as one formulates the question, thinks about the practicalities, brings together the collaboration, and actually really convinces people that this is the question that they are going to commit their time and energy to. And Colin started this process with his master's thesis in 1995. And I was just saying to David, neither he nor I actually have a copy of that, but I'm pretty confident you still do, Colin, in which the back page of it from memory in the appendix was, I think we need a large factorial trial of aspirin and simvastatin. And I can still remember the figure the first time I saw it. So that consideration about having a large trial in kidney disease patients really started with Colin's thesis in 1995. As David alluded to, I was in Birmingham 96 to 2000 or thereabouts, and was sort of working at this problem in my own definitely amateurish way. And I was very grateful to David for the connection, but I'm even more grateful to Colin, who taught me everything I know. He's responsible for how little I know about epidemiology and really inspired me in the whole field. He taught me by giving me 2 books, which I read on the train between Whitney and Birmingham each day, and then actually helping me to think through some of the issues and some of the rationale. So if you want a sort of summary of Colin's work, actually, first author Colin Baigent, last author David Wheeler, it's this, which appeared in The Lancet in 2000 as a review. There is a remarkable lack of reliable information about the determinants of risk of cardiovascular disease among patients with chronic renal failure. That's what it used to be called. Such patients will often be deliberately excluded from trials, perhaps because of concerns about drug safety. But the absolute risk of cardiovascular disease among them may be large, so the potential absolute benefits may also be large. We need trials, and so it went on. And one of the sort of 2 strands of work, I think, that Colin contributed to the area of chronic kidney disease. The first was among people with chronic kidney disease, how do we reduce risk of renal progression, risk of cardiovascular complications, and so on. And the other was quite different, which was saying amongst the general population who by and large are thought not to have chronic kidney disease, what's the relevance of kidney function to cardiovascular risk in that particular context? And I think I'm not going to talk about that bit because that wasn't my title. I'm not sure that anybody else is, but we should also recognize that this whole shift towards thinking about kidney disease and its contributions to cardiovascular disease in the general population really, I think, stems from a lot of the work Colin did way back when. And of course, as I said, in the first instance with clinical trials, you have to lay out the groundwork. You have to set out the hypothesis and justify the hypothesis. Why do we need a trial? And so by the time I arrived here in 2000, some bits of evidence were beginning to emerge. But I think in my mind, it was Colin who was really pulling them together in a constructive way. This is not our work. This is work from the United States Dialysis Register, but really demonstrated that there were colossally higher risks of vascular events amongst people on dialysis than there were amongst the general population. The top line, this is a logarithmic scale. The top line is mortality from vascular events amongst dialysis patients. The other 2 lines at the bottom are the age effects, so age-associated effects on risks of cardiovascular disease amongst the general population. Number 1, these people are at colossally high risk, but these are dialysis patients. The question is a little bit about what about people who are earlier in the stage of disease. The second thing, I think Richard alluded to this earlier, was that the heart disease, they may be at high risk of heart disease, but the heart disease is not common and garden heart disease of the sort that cardiologists see. I'm sorry you've just had lunch, but there wasn't a steak on the menu. That's a heart at the top left. You can see that the heart muscle is enormously thickened. That's a heart at the bottom right. You can see that there it's all been stretched up and dilated. These are not classic pictures of someone who has had a heart attack or about to have a heart attack. The disease mechanism is quite different. Same thing on the top left-hand side, these sort of structural abnormalities in people with echocardiograms were prevalent, and on the bottom left, there was also a lot of calcification in the coronary arteries. But this is not classical atherosclerosis. So it's by no means a certainty that this colossally high risk of cardiovascular disease is driven by the same things that the risk of cardiovascular disease is in the general population, the sorts of people that we see in cardiology clinic. So I thought I'd better show one slide from my PhD and credit it to Colin, but this is actually what happens when you look at patients with kidney disease at various stages. Now, I would replot it again if I was doing my PhD again. I hope never to do that. But what it's saying is that compared with healthy controls, this is LDL cholesterol on the y-axis, you can see that as the kidney function is worse, among those who've got worse kidney function, the cholesterol is actually getting lower, which sort of feels a bit counterintuitive. It's not, there's an explanation, but it sort of feels a bit counterintuitive and rather suggests to you that lowering cholesterol in these people at high risk, their cholesterol is already normal. Why would you want to lower it further? These are the words of the time. Richard, please refrain from asking me questions just now. And then if you look at the association this time between total cholesterol and this time the risk of death, again, this is the quality of the epidemiology we had at the time. It's not very good. But what you can see is people with lower cholesterol at higher risk. So again, it raises this question about whether lowering cholesterol would actually lower risk. It's not the sort of association we've seen in the general population. Now, of course, there have been plenty of trials, or a number of trials of statins in lowering cholesterol in the general population, including the heart protection study, which is actually the first study I worked on when I first came to Oxford, along with Louise. And this is the data from the heart protection study. You can see a reduction in cardiovascular events of about a quarter. But when you look at, and you can see that there's improvements both in those who've got high creatinine, low kidney function, and those who've got normal creatinine, sort of normal kidney function. But actually, those are very trivially sort of mild levels of kidney impairment. There were only 128 patients who had chronic kidney disease, no heart disease, the sort of patients we wanted to go on the study. So that is the background to what we went on to look at. We have this high risk of cardiovascular disease. The kidney disease, though, is atypical. Sorry, the heart disease is atypical. The epidemiological associations are really very unclear. And basically, people with kidney disease have been excluded from all the previous trials. And Colin would make the point that even if they had been included, because kidney disease is a special and not terribly common population in the grand scheme of the general population, even if they'd had very broad eligibility criteria, we still wouldn't have had an answer in people with significant kidney impairment. And the consequences of that was, despite knowing a lot about how statins lowered the risk of cardiovascular disease in the general population, we really had no idea what the situation would be amongst this group of people. And so Colin's master's thesis, the first task, which was actually started before I came here, but I can see Craig Leeper in the audience, was to convert that into the first UK heart protocol, which was studying at the times a low dose of simvastatin versus placebo and in a factorial design aspirin versus placebo. I'm not going to spend time on the aspirin piece, except to tell you that that didn't go any further for a variety of different reasons. So that demonstrated a reduction in cholesterol of about 0.8 millimoles per litre. That's between these top two lines. And that didn't seem quite enough to test the hypothesis of whether a big reduction in cholesterol would lower risk in people with cardiovascular disease. And just at that time, a new drug, as it was then, called ezetimibe, which prevents the absorption of cholesterol, had come along. And therefore, we did an additional study of simvastatin versus adding in ezetimibe. You see an additional reduction in LDL cholesterol. But essentially, to us, what it was a combination treatment, but it was a safe way, at least on the basis of a few small numbers, a safe way of getting a big reduction in cholesterol, and therefore a tool with which to test the hypothesis. And so that brought us to the SHARP trial, which we established in early 2003, which Colin and I set out to answer exactly this question. If you could get a big reduction in LDL cholesterol, would you reduce that high risk of cardiovascular events? Or, as, for example, some of the epidemiology, some of the pathology suggested, was all this heart disease of a completely different nature and essentially structural and going to be irreversible and not respond to changing the cholesterol levels? And so we moved to the
the trial itself. We took patients who had a history of chronic kidney disease. How did we define that? Well, we said if you weren't on dialysis, then they had to have a high creatinine. Now, again, the kidney doctors in this room will say, well, why were we focusing on creatinine? That was the measurement that was being used. And the GFR measurement, which is a calculation of that, was not regularly being reported in many labs around the world back in the very early 2000s. It actually translates into, by the time your creatinine is over 150, your glomerular filtration rate is low. It's a question about just how low we can calculate that. So we took people who had impaired kidney function or who were on dialysis, either hemodialysis or peritoneal dialysis, 2/3, 1/3, so 6,000 patients, 3,000 patients over the age of 40 who'd not had a heart attack or a coronary procedure in the past, and in whom their own doctor was uncertain, indeed the patient was uncertain whether a cholesterol lowering therapy was definitely needed or was definitely a bad idea and contraindicated. Now that uncertainty principle is important, but one of the things is, as I will illustrate in a moment, is that people's level of uncertainty waxes and wanes as you go through the trial. And that, again, is a common feature of trials, is that people often think that they know the answer, and they can be convinced they know the answer. And a few months, years later, they're then convinced that they know the answer and it's the opposite one. And our job is to steer through all that and then come up with the true answer in the sense of the results of the trial, despite all that tide coming in and going out. Now, as a complicated randomization, I take you through it. Essentially, we took our 9,500 patients. The real question was lots of cholesterol lowering versus not, and is there a reduction in cardiovascular events? But for regulatory reasons, given that the ezetimibe was a relatively new drug, we had to be able to demonstrate to the regulators that the ezetimibe wasn't just a sort of white powder doing something trivial on the side, but it actually contributing to the overall effect. So a bit like that pilot study, the first year we had an intermediate arm, which is basically saying, this is how much cholesterol gets lowered with the statin. This is how much further it gets lowered when you add in the ezetimibe. And it was for a regulatory purpose rather than for anything else. What we wanted to study was a lot of cholesterol reduction versus placebo. The primary outcome, as I've alluded to, was major atherosclerotic events. We took some care over that, trying to take out those events which were very clearly due to that sort of structural heart disease, the sort of heart disease which is unlikely to be modified by cholesterol lowering, or so we thought. And then we also were testing the hypothesis about actually whether cholesterol lowering would reduce the rate of progression, which we measured as progression to end-stage renal disease. So as I say, between 2003 and 2006, we randomized over 9,500 patients in, I think it's 14 countries. Colin and I spent a lot of time in airports together, going around the world, trying to explain to people what the trial was about, why trials were important, why the question had not already been answered. And we had considerable support, not only from colleagues here, but also from colleagues around the world in pulling this together. So I've mentioned a few times that with trials, the question is, how do you keep them going whilst you're waiting for the answer to come? The excitement at the beginning when you get the grant and you get the first patient in, the excitement at the end and the answer. I remember very early on speaking to Rory, it might even have been the day before I started, because of course being Oxford, they invited me and told me I should give a talk to the HPS nurses the day before my contract started. And I didn't feel I could say no, but I remember talking to Rory and he said, the thing about trials is people don't think that what they ask, what do you do between the starting bit and the finishing bit? And Rory's answer was firefighting. What you do in between is fight fires to try and keep your trial going as long as it needs to go to answer the question. Put it differently, it's about events, dear boy, events. Now, when Harold Macmillan may or may not have said that, I don't think he meant 43,000 serious adverse events, which is the scale of the data we collected during this. I don't think he meant the 10,000 events which we went through careful hand adjudication, here helped by Father Christmas and his mate. But I think but it was, that adjudication effort was all in an attempt, partly scientifically to filter out heart disease, which was likely to be modifiable cholesterol lowering, and from that wasn't, and partly because It's a piece of show business that the regulators and many others demand. And as actually, when we finally went back and looked at it, it actually was an unhelpful thing to have done, not a helpful thing. But that wasn't dealing with serious adverse events wasn't our only challenge. Sharp found a new home. This is Sharp Towers. You're in the building now. When we moved up here in 2005, I can remember Marion and I, because we had a randomization service on the telephone and we needed to have emergency unblinding capabilities, Marion and I each took separate packs of paper away for the weekend in order so that we could, if somebody happened to need unblinding as an emergency over that weekend, we could each look at our part of the envelope and then compare notes as we spoke to each other. Thankfully, it wasn't needed, particularly as I was camping in somewhere in South Yorkshire. But what about results? Yeah, so as I say, we started this trial in 2003. About that time, a kidney disease trial in people with transplant of 2,000 people came up, studies one a statin, a borderline result. Essentially, this treatment doesn't appear to lower the risk of cardiovascular disease. The 4D trial from Christoph, who's here, there he is, who showed beautifully in one American Society of Nephrology meeting that amongst his 1,300 patients with diabetes and hemodialysis, that again, cholesterol lowering didn't have any impact. The Aurora trial, largely from Scandinavia, again showing that, or concluding that giving statins to people on dialysis wasn't of any benefit. And so you can see that there's this, the evidence is piling towards these drugs don't work. I have to say that actually the practice and the clinical guidelines were heading the other way. The clinical guidelines, which were actually even produced in 2002, 2003, said patients with kidney disease are high risk. They should be treated like high risk patients. They should all be given a statin. That included those guidelines written by some members of our own steering committee, which I have to say was less than helpful. But those are not the only things. That's on the sort of efficacy side. Do we, has the tide gone towards treating everybody statins or away from everybody treating with statins? There are other challenges, and this one is a particular learning experience. A trial called SEAS. It was a study of ezetimibe, a trial in people with a disease called aortic stenosis, narrowing of the aortic valve. Now, it didn't work for that, but it produced amongst its results this one at the bottom, which says there are 100 cancers in the people who got ezetimibe and 65 in the people who didn't. And the p-value is clearly statistically significant. This is a hazard. And we were phoned up and told about this result. The head of R&D at Merck, the company that make ezetimibe and simvastatin, was minded to pull the entire drug, including the entire trial. This is in 2008, so we're about 2 years off when we will finally have the results. We've done all this work, we're midway through follow-up, and this result pops up. And with a lot of effort, in a very short amount of time, like a week, we managed, and particularly Richard Peto managed, to pull together the data from the ongoing SHARP trial, the ongoing Improve It trial that Rob Califf was running in the United States, gather that information together and present and refute that hypothesis with substantially larger numbers. So it was in short time. I remember getting in a taxi here with facing backwards with Richard, and I said, "Richard, where's your slides?" We didn't have a single slide at the moment we left Oxford. And by the time we got to the press conference in Paddington an hour later, somehow we had a talk together which convinced people that we should, after all, keep going. But this could have completely killed a drug, completely killed a trial, and our ability to study the question. So roll forward to 2010, and the rest of these slides for the next few slides are the slides we showed in 2010 at the American Society of Nephrology. These are the results. So as I said, we randomized 9,500 patients. Now, as is often the case, particularly in people with chronic kidney disease who've got many medical issues going on and are on dozens and dozens of treatments, most of which have no evidence about whether they're the right treatments or not, but they are on dozens and dozens of treatments, then compliance or adherence to the therapy is somewhat challenging, particularly as it's worth bearing in mind that the trial therapy is always the one that you stop first. So of all the drugs that people are on, and the patient says, "I'm taking too many tablets," the first one that gets stopped is the trial therapy, and particularly the trial therapy because you don't know whether it's any use or not. And so what we saw was that 75% or 70% of the people on the active group took the treatment. 8% of the people on the placebo ended up on treatment. So we had about 2/3 compliance. Our 1.2, 1.3 millimole per litre difference between on those pilot studies was now 0.85 millimoles. So we had less power, less ability to tell the effects of the treatment we might otherwise do. On the other hand, if we saw a clear benefit, then actually you can make an estimate that the benefits would be substantially greater if people actually swallowed the tablets, which is Landre's first rule of clinical pharmacology. If the patient doesn't swallow the tablets, they're unlikely to work. And so this was the result that we found, was that the risk of cardiovascular events was reduced from, I can't remember, about 15% to about 12%, a significant reduction. And that was the first time that we really had demonstrated against all that previous literature, the observational epidemiology, the pathology, and the previous trials, that there was an effect. Not only that, we can play Colin's work on kidney disease in the SHARP trial back into his work on the CTT and the meta-analysis. And these again are slides from that presentation. This is a sort of reworking of the slide that both Richard and Kirsty showed earlier on. That if you get big reductions in cholesterol, that the extent of the reduction in cholesterol is related to the extent of the reduction in atherosclerotic events. What we saw in SHARP was that we managed to reduce LDL cholesterol by about 0.85 millimoles per litre. And very neatly, you can see that actually that 17% risk reduction which we saw sits pretty closely to that line. Now, this is an underpowered but it gives you a sense that both the simvastatin and the ezetimibe were contributing. It's about LDL lowering rather than any magic of one drug or the other. A couple of other results. So that was good evidence for ezetimibe, let alone actually answering the question for patients with kidney disease. We looked in many subgroups. There was essentially no difference across all the different subgroups. There was a huge amount of discussion, particularly given those dialysis studies, about whether there was a significant effect in patients with dialysis. I think Colin and I would both put our faith in the overall results, and particularly in the context of the breadth of the CTT. Those people who are versed in nephrology rather than in the overall sort of statin literature in the CTT were putting a lot of emphasis on this. And in the end, I think that argument at the time won. I'd be interested from the nephrologist where we are now, but I did even say very few people pitch up on dialysis as their first ever presentation to patients with kidney disease. So in a sense, it was only a question of what we do now. People with chronic kidney disease who will progress will already be on a statin, and there certainly wasn't a good reason to stop it. The kidney disease question, unfortunately, was less successful. Lowering cholesterol reduces the risk of cardiovascular disease, doesn't do anything to the kidneys. And what about that cancer stuff? Well, there was an imbalance in the number of cancers. There were 438 in the active treatment group. There were 439 in the placebo group. This drug could have been killed off by a study of 101 cancers versus 65 cancers. Patients with kidney disease would not be getting lipid-lowering therapy if that trial had been stopped at the time. So I won't read the conclusions. These are the conclusions from the trial. But this was really the first demonstration of the effectiveness of the treatment. And I've got here what I read at the time when Colin and I presented this. So what does all this mean for patients with chronic kidney disease and their doctors? Over the past couple of decades, we have increasingly recognised that even moderate chronic kidney disease is associated with a high risk of cardiovascular complications, and have realised that kidney disease is common. But we have failed to identify any treatments that are effective in reducing that risk until today. The SHARP results provide clear evidence that lowering cholesterol with ezetimibe and simvastatin safely reduces the risk of major atherosclerotic events. That is the culmination of 15 years of work by Colin, supported by others, but by Colin. If I think about the reflections more broadly, this was not only a clear demonstration of the benefits of lipid lowering in this particular population, but this was also a clear demonstration that large randomized trials in this population are worthwhile and are actually possible. And that spawned a whole generation of large clinical trials since, and others will talk about some of those. But more importantly, well, not more importantly, as importantly, it's also established an entire new career path for academic nephrologists and a better future for patients. There was a point at which I thought we probably had more academic nephrologists in this department than they do in the Department of Medicine. It's certainly a big swing to getting nephrologists interested in epidemiology and trials. I'm going to finish by completing David Wheeler's story. In fact, actually a question Rory asked me just now. How did Colin? I can't remember how Colin first introduced you. So this is a memorandum. This is in those days CTSU didn't use email. This is a memorandum from 1999 from Colin to Rory and Richard. As you may know, Martin Landry is a senior registrar in Birmingham. He's doing his PhD. He's officially due to start to finish on the 1st of January. I'd like to find a salary for him to come and work with me on the heart pilot and main study. Now, you can judge Colin's insight and wisdom when he says he needs exposure to mainstream epidemiology. That's true. But I think he is bright and clinically astute whilst realizing the need for trials and prospective studies. The most entertaining thing, though, at all, is what Richard Pito wrote on the bottom. Okay, as long as Visit doesn't get taken as a definite job offer. And so with that, I'd like to say enormous thanks to Colin for years and years of putting up with me. But he has made a substantial difference to my career, to many other people's careers, but most importantly, to the whole area of science in kidney disease, and even more importantly, to patients in kidney disease, which is the thing that is closest to his heart. And we should all be grateful for that. Thank you.
Thanks, David, for the introduction. I have to say, when I first met Colin, I had no anticipation of ever being here to be giving a talk like this. When I first came to meet him, I was a nephrology trainee, hadn't been a registrar for very long, but I was in search of some research time. It's what you did. You're an Oxford nephrology trainee, not just any nephrology trainee, and this required some research experience. And I was looking around. I was recommended one supervisor in the Department of Primary Care, who then slipped a disc in his neck, so he escaped. I then asked Chris Reynolds if he had any other ideas, and he said, well, there is this person called Baigent who seems to know something about epidemiology. Why don't you go and have a word with him? So I came to Colin's office. I remember talking to him then and feeling slightly overwhelmed, looking at Colin's filing cabinet, by which I mean all the papers that he distributed over the floor of his office at that time, and alighting on one about aspirin, which I think we've already heard about this morning. And thinking I could say something intelligent about that, because I had just read something in one of the journals about that, started talking about how aspirin didn't really work in women, mainly worked in men, and received my first lesson from Colin in subgroup analyses, but he still kept me on. So I get to talk to you about the 3C study. You've heard a huge amount about really big, really impressive studies. I'm now going to talk to you about probably the smallest trial, or one of the smallest trials that Colin's ever been involved in. But before I do that, I just want to talk a bit more generally about trials in kidney transplantation and transplantation in general, if I can get the thing to move. Is that working? That's working. Brilliant. So kidney transplantation was developed in the 20th century. There are some scattered reports from right back before the First World War of transplants. Nobody really knows whether they're real or not. There were some rather maverick Russian surgeons giving it a go later on in the century, but it really came to prominence in the 1950s. When this picture here was taken during the operation led by Joseph Murray in Boston, taking a kidney from one identical twin and giving it to his twin. And it was the first really successful transplant. It avoided all the problems with immunosuppression. And so this transplant worked for 9 years or so until the recipient unfortunately died of unrelated causes. But I'm just going to digress into talk a little bit about dialysis, because dialysis and transplantation have quite a close relationship. And actually, before I was preparing for this talk, I didn't realize quite how close. So the recipient here, I think it was John Herrick, who received the kidney, had been on dialysis for a short while in Boston, and his dialysis was delivered by a British man who'd gone out to learn the art of dialysis, as it was then. It wasn't so much a science as an art. And he'd gone out to learn. He'd dialyzed this man up until his operation. And then he came back to Leeds to help work in the first artificial kidney unit. Dialysis wasn't a very popular treatment at the time. It had been developed really after the Second World War had ended, when there were many soldiers surviving injuries after people learned resuscitation with normal saline. Apparently that used not to be a thing. Strange for us doctors to think about that. But dialysis became important when people were surviving, but they had acute kidney failure. And that was largely because heparin had been invented, a way of thinning blood so you could keep it flowing outside of the body. And also that sausages had been invented so that we had the cellophane skins in which sausages were made to act as that semi-permeable membrane. But that was dialysis for acute kidney problems when your kidneys fail temporarily. But dialysis as a lifelong venture was much less popular, partly because transplantation didn't exist, and transplantation was considered to be the best exit strategy. It still is the best exit strategy from dialysis. But it wasn't popular here, and it wasn't popular with two groups of people who are particularly close to Colin's heart. I think Colin, it'd be fair to say, Colin has had a love-hate relationship with both the Medical Research Council and the Lancet during his career, and both of them had things to say about dialysis early on. So the Secretary of the Medical Research Council, Sir Harold Himsworth, went up to Leeds to visit Parsons. He was the man who'd gone out to Boston to learn how dialysis worked. He visited the artificial kidney unit in Leeds, and this is what he left saying: try it, Parsons, but remember, the country is against you. So the MRC may be the first mistake. Then comes the Lancet. So an editorial written just the year after Colin was born. It is doubtful whether this therapy should generally be practiced, and our limited resources should not be squandered on mass dialysis for suitable patients with irreversible renal failure. So this is the situation that was real at the time, and if it wasn't for the battling of many patients and their doctors acting as their advocates, maybe that dialysis wouldn't ever have been a practical treatment. But if you do have to have dialysis, transplantation is definitely the best treatment for you. A successful transplant, the benefits are very, very clear. The picture on the left, these are American data. They are old. It's probably still true that if you have a transplant, compared to your peers who remain on the waiting list, remain on dialysis, acutely you're at a higher risk of death because you've just had major surgery. Maybe that's not surprising, but 100 days later, your risk is back to where it started from. And then after less than a year, and certainly from a year onwards, your risk of dying is then 3 times lower, if not more. So transplantation is one of those treatments which possibly you don't need randomized trials to show the benefit of. The effects are so large that you don't really have to worry so much about bias. And the effects of transplantation can be seen in other sources of data. So I can see we've got Charlie here and Natalie, led by Will, who did a remarkable piece of record linkage work, which Colin also got his hand in, where they compared, I'm sorry it's a bit small, but they compared 3-year mortality rates in the general population, the line along the bottom on the left-hand side, and the rates amongst people with kidney failure, going right back to the 1980s. Is Ben here as well? I don't know if Ben's story. This was a large part of one of Colin's early trainees' MD thesis, and you can see that the rate of death falls very dramatically amongst those people who had end-stage kidney disease, and part of that will be the effects of transplantation, the benefits of transplantation. So transplantation has been very successful, and it's getting better. Each of these lines corresponds to a different cohort in 5 years, and you can see that in terms of graft survival, so this is keeping the transplant working, which if you're a transplant surgeon is pretty much all you care about sometimes. If you keep the transplant working, that's what really counts, and that's got better and better, but it's not all perfect. Now, the reasons that transplantation has got better are manifold. There's been surgical ingenuity, the people who invented the technique in the first place. That work was largely finished over 100 years ago, how to do the surgical anastomoses. There's been huge work in immunology, some of it led by other parts of this university, a lot of ingenuity, and some trials as well. But one of the key areas has been immunosuppression, which has changed quite a lot over the years. The first 20 years, you can see here, there are only really 2 agents available, and they were used in combination. One was steroids at very high doses, and the other was azathioprine, which came along. And that really was the only treatment for the first 20 years or so. Now, I wasn't around to see kidney patients at that time, I'm pleased to say, but these were not the halcyon days. From what I hear, this was a very difficult time. Patients receiving these very high doses of steroids had a very, very rough ride indeed. There was a serious risk of death from complications of steroids, mainly infections, There are risks of skeletal abnormalities because steroids have very bad effects on your bones. And transplantation, as this slide sort of shows, if you look at the bottom line, the blue line there, you can see it was a bit binary, that if you got a transplant, there was almost a 50-50 chance of whether it worked or not. If it worked, then it might stay working for a little while. If it didn't, then be back on dialysis. And it's just worth, as Richard mentioned earlier, the 1980s when Colin had his first transplant, so he has lived through this and seen all of this. But then a new drug appears there in orange, which is cyclosporin, and that starts to change things. So cyclosporin and then tacrolimus come along, and these two agents I'll come back to later. These are the calcineurin inhibitors, but what they dramatically affected, dramatically reduced the risk of acute graft loss, but they may have had some other problems following on. There are then some other drugs have been developed. Probably their adoption was hampered by the lack of good clinical trials. Tacrolimus became a competitor and then largely replaced cyclosporin, but it took a very long time for that drug to go from being invented and tested and actually then get approval by regulatory authorities, because the standard of the randomized evidence was really quite poor, which they were using. Mycophenolate, the line in yellow, has largely replaced azathioprine, the line in green, and that is more of a marketing success of the manufacturer than a scientific success in demonstrating benefits. And these were some of the trials that were around at the time. So a local trial led by Peter Morris in the 1980s compared those huge doses of steroids with much lower doses of steroids. 72 people, a hand-drawn Kaplan-Meier plot, apparently showing that they were equivalent to each other. I'm not sure that would stand up to a huge amount of inspection now. And when cyclosporin was introduced, here we've got 230 patients being compared with cyclosporin versus azathioprine and steroids. In the days when people thought you really should only have one drug to suppress your immune system, we now use combination therapy. Things did get a bit better. This is a trial of 1,600 people comparing 4 different maintenance regimens, and this largely now defines the current standard of care, at least in Europe, for many patients having kidney transplants. So showing that 1 year graft function, how well your kidney is working 1 year after it's transplanted, is better if you receive tacrolimus than you receive either normal or low doses of cyclosporin or this other drug called sirolimus, which I'll come back to. But again, a trial with 1 year follow-up, so bigger numbers, but not very much follow-up. And so this is where the 3C study came in. So the characters involved were Peter Friend on the left-hand side, professor of transplantation surgery, Paul Harden, a local nephrologist. They knew that I was interested in trials. They knew I was thinking of coming to CTSU, and they suggested to me that I might like to work on this trial. Martin heard that, and I remember Martin saying to me that you can work on that trial if you can raise the money, which we fortunately did. And then Colin there, really overseeing it and making sure that the trial was designed and done properly. Richard's already stolen one of my jokes for the afternoon, which was to point out that Colin could always pull off a good shirt when he needed to. So why did we do the 3C study? What was it that we were trying to address? Well, I've shown you that the introduction of cyclosporin dramatically reduced the loss of kidney transplants in the first year, but after that, kidney transplants did continue to fail over time. And it wasn't entirely clear what that was. Could that be due to rejection? Well, there didn't seem to be much evidence of immunological rejection when you looked at these kidneys under the microscope. Could it be infections? Again, not a huge amount of evidence, but one thing that did seem to show up was toxic effects of those calcineurin inhibitors. So the very drug that was keeping the kidney happy for the first short period might then be contributing to its later failure. And so the fundamental question that the 3C study was trying to answer was whether if we could minimize the exposure to calcineurin inhibitors, could we improve outcomes? So the graph on the right there shows that if you do regular biopsies, which some people in Sydney, Australia were doing every year on their patients, actually had a kidney pancreas transplant, but this is looking at the kidney, that by the time we got to 10 years after transplantation, it was pretty much ubiquitous that you had evidence that you'd had too much calcineurin inhibitor. So maybe reducing that would work. So we thought about how to do it. I was really interested to hear about the stories about the stroke thrombolysis meetings where you had fairly strong personalities in the room. I can remember talking at this lectern when we had all the transplant centres from the UK, transplant surgeons from across the country arguing about precisely how they did kidney transplants and why it was better than each other. And I think Colin's diplomacy shone through there, managing to keep them all happy and signed up to a single protocol. But it was a single protocol. Could we give them some sort of treatment when they first had their transplant called induction therapy, which is typically an antibody-based therapy, often a monoclonal antibody, which if you gave it, it could rapidly or dramatically reduce the risk of rejection. You could dampen the immune system. But if you gave them a particularly strong version of that called Campath on this slide, then it may be that you could get away with giving them less other immunosuppression to go along with it. So give them less tacrolimus and maybe get fewer toxic effects from doing so. So that was one of the questions we sought to address. The second question we sought to address was after 6 months, hopefully once the kidney was stable, could we remove calcineurin inhibitors completely, take them off tacrolimus and replace it with a drug called sirolimus, which was popular at the time because it seemed to be pretty effective at suppressing people's immune system, but was not, although it sounds like it was not the same class as tacrolimus and wasn't toxic to the kidney. So there were two questions we were trying to ask. I think lots of people thought we were a little bit unrealistic in our aspirations of trying to recruit a fairly large number of kidney transplant patients just in the UK. But we set off in 2010 and over a couple of years did manage to recruit over 800 people having a kidney transplant. And that was about 1/4 of everybody who had a transplant at a participating unit in the time. So we really managed to get the centres to buy in and recruit patients for us, which was fantastic. It was very gratifying once things got going to see that we could keep recruitment going. We were actually asked to stop recruitment because there was another trial coming along that wanted to sort of use the national pool and take over. And I was interested to read only a few weeks ago that that trial is still actually yet to start. But anyway, and we did have some early success. We measured tacrolimus. You can measure the drug level in the blood. We could see whether we were actually achieving what we wanted to achieve. Were our patients getting less of it? And the answer was yes, they were. In that first 6 months, when everybody got some, people who were given the more powerful Campath or alemtuzumab on this slide were getting significantly less exposure to the drug. So maybe that would translate into improved outcomes. But the first outcomes that we wanted to look at, really, rather than the efficacy, which was always going to be a long-term question, was really almost a safety question, that by doing this, by changing immunosuppression, were we going to actually cause more rejection episodes, which are probably one of the most feared complications after a transplant, certainly by patients. Would we actually cause an excess of those by giving them less immunosuppression? Well, that's partly why we used Campath or alemtuzumab, because it was so much more powerful than basiliximab, certainly because it was actually removing cells from the circulation rather than its alternatives, which just tried to switch them off. And so when we looked at rejection over the first 6 months, we actually saw that we did dramatically reduced it with Campath. So this was the first ever Kaplan-Meier curve from a trial that I had really closely been involved in, that I got to see, and it was very exciting to see an effect that big. And you can see that rejection is really quite uncommon with alemtuzumab. But then we were told that, well, if you suppress people's immune system that effectively, this is going to have consequences. You can't do that and then not cause a whole load of infections. You're going to have caused some problems. So we collected information on every sort of infection we could imagine. Some of the infections called opportunistic ones, which are infections that only people who are immunosuppressed or immunocompromised get. And also the infections that anybody all of us are susceptible to. And it didn't really matter how you looked at it. Overall, no more infections with alemtuzumab than with basiliximab. So you really can have your cake and eat it. It seems you can reduce your risk of rejection without paying the price of increased risk of infection. But the second thing I was told was that effect on rejection was just short term. That when the alemtuzumab wore off, which it does after about 6 or 9 months, then all the people who'd had alemtuzumab, they would then get their rejections just a bit later on. And in fact, that would be bad because you wouldn't be observing them quite so closely 6 months after a transplant as you do in the first few weeks. And so their rejections might take hold. but we followed people up for a year, absolutely no signs of a catch-up. So it seems that alemtuzumab wins in the short term. What happens in the long term remains to be seen. But as I told you, there was two parts to the 3C study. There was this bit, which was the treatment you give right at the time of transplantation. And then after 6 months, we either kept people on tacrolimus or we swapped them to sirolimus. This was less successful. During my first 10 years or so of doing trials, these were the sorts of results that I got more accustomed to seeing in trials that I was involved in, which were the drugs weren't very well tolerated. You can see that sirolimus, only about half of people were still taking it 18 months on. It was badly tolerated, and it also wasn't doing what we wanted it to do. There was a big increase in the risk of rejection with people given sirolimus, and there was an excess of infection as well. So it really seemed that sirolimus really wasn't doing what we wanted to do, and especially when we looked at people's transplant function, we can see here absolutely no effect, no benefit for sure with people given sirolimus. So this was a bit of a damp squib, and sirolimus has largely now disappeared, not just because of these results, but because of others from the armamentarium that people use in kidney transplant patients. But there's more yet to come from 3C. I'm sorry I don't have it to show today. I did sort of hope that I might be able to, but in many ways, COVID came along and has caused quite a disruption in getting data in the first place and in collating it and then having capacity to actually analyze it. But one of the unique things, or at the time unique things we did with 3C was to flag patients with registries, not just for long-term follow-up, but for the deliberate follow-up within the trial as well. So patients, we have data in the department now, whether they've lived or died, what they've been admitted to hospital for, whether their transplant is still working, and if it is, how well is it working. All of those data we could collect through registries routinely. And we now have 12 years follow-up in all. So hopefully when we do get to analyze those data, they should be very interesting. So trials really do matter in transplantation. In Colin's lifetime, kidney failure has changed from being a fatal disease now to one which we can manage quite successfully. And I think Richard said earlier that probably one transplant can save thousands of lives in the case of Colin. It's a very good tool that we have. It could be even better. And I think it will take more trials to do this, although many of the early advances were, if you like, the low-hanging fruit, the things that are easy to identify. I think future improvements are definitely going to need trials to unpick what works moderately from what doesn't work at all. So I just want to finish briefly by thanking Colin for all the opportunities he's given me, one of which in particular comes to mind is the last opportunity he gave me. Many of you know, CTSU got core funding from the MRC for many years. Originally, Richard and Rory were leading the CTSU, but about 8 years ago, Colin took over the reins of the MRC Population Health Research Unit. A year or two ago, the MRC had a strategic review and decided they didn't want their units anymore, and they were going to gradually phase them out. And around that time, Colin offered me the opportunity, completely coincidentally, to take over from him as director of the Population Health Research Unit. So now I had the pleasure earlier this year of actually closing the Population Health Research Unit. And as Colin reminds me, it was all going absolutely fine while he was in charge and not so fine thereafter. Colin's taught me an awful lot verbally, helping me write papers, learn about epidemiology, among many other people here. But Colin's also taught me an awful lot without anything he's ever said. Trials in transplant really matter, but every single one of those transplants is an individual story. And it's sometimes far too easy to forget that as a trialist, that when we do these things, we've got thousands of people in our study, but each of those is a life that really matters and is a story of its own. And Colin's bravery with his particular fight with kidney failure has been a real lesson to me, and I'm very grateful to him for letting me observe it and teach me through it. So thank you very much.
Thank you very much, David. There aren't many bigger leg ups in life than what Colin offered me when Empa Kidney started. I'm incredibly grateful for everything he's done for me, but many other people in this room are major contributors, and Richard Haynes could easily be standing next to me giving all this talk as well, because we worked as a pair off the back of Christoph Fanner's analyses, which I will show you a little bit more about in a second, because they were fascinating. I remember exactly where I was when I was reading them. I was outside resus training in the Oxford University hospitals, and I saw this paper and I left resus training without doing it and came here and started thinking about exactly what we should be doing with this. And that's how EMPA-Kidney in my head was born. But the reason I was at CTSU in the first place was because I felt that we had a world which is in crisis. About the time I was finishing medical school, the key medications which would slow kidney disease progression had been identified, but there was little to be discovered for the next 2 decades. So the IDNT and the renal trial were published in 2001 and demonstrated actually only in people with diabetes and with proteinuria in their protein in their urine that you could slow progression by about a quarter. But they also demonstrated that although you could slow progression to end-stage kidney disease and prevent dialysis, the residual risk was incredibly high. And what was sad was that most of my renal training, the trial data that I was shown in conferences was small in scale, and this slide was actually much more commonly presented than actual data. This was a slide tracking over time the numbers of trials published by the nephrology community from the 1960s through to 2001. And you can see that not only was it the community which published the lowest number of trials, it also didn't demonstrate any growth. When I came to CTSU in 2010, I was told to come here by Father Christmas because there was a lot of adjudicating documents to do in Sharp. So I joined him and we spent 3 years. We learned an enormous amount about how to do trials from the fathers of the renal studies group, Martin and Colin. But 10 years later in 2014, despite the fact Sharp had published, actually not much else had changed within nephrology. There were nearly 41,000 trials registered on clinicaltrials.gov that year, 2.6% within nephrology, and rather depressingly, 2/3 were less than 100 patients, and again, about 2/3 were going to be unblinded. So at that point, I made a decision that I wanted to do trials. I was trying to follow in Richard Haynes' footsteps and be encouraged by Mariam Maffam. My mission was to join him to try and avert this crisis. And Colin and Martin kindly trained us over time. But it was a couple of years before we found the agents we really wanted to study. This rather chic gentleman on the right had serendipitously identified within the EMPA-REG outcome trial, which David has kindly introduced and saves me a good minute of my talk. But with this trial, which was trying to identify whether or not empagliflozin, an SGLT2 inhibitor, was safe, had stumbled across these very interesting kidney results. And I'll orientate you, the non-nephrologists. So this is a medallion. This is kidney function, and this is over time. And you can see that either dose of empagliflozin caused this dip in kidney function, and then a remarkable almost arresting of the rate of decline. If you compare those allocated to placebo, there is an almost linear rate of decline. And these blobs here are data which Christoph requested that were added, which was post-treatment assessments of kidney function. Now, this is the first time we had seen this in nephrology, this recovery of acute dip. And what was explaining this, well, probably was a concept called hyperfiltration. I don't want to lose you with this diagram, but this is a diagram of a nephron. There are about 500,000 to 1 million in health, very variable numbers. But what they do is they filter the blood. The capillary network you can see in the middle is the glomerulus. And the filtrate, which includes essentially sodium, glucose, and everything from the blood which can pass across the membrane, is then processed in the tubules and comes out eventually as urine after being highly processed down here. But this is a kidney which is leaking blue blobs of protein, and this glomerulus is diseased. It is actually larger than it should be. It's hyperfiltering. So what SGLT2 inhibitors do, in actual fact, they get filtered through the glomerulus and they target the sodium glucose co-transporters. And that's where the majority of glucose and 90% of the sodium in the normal functioning kidneys are absorbed. So it blocks their function, causing the glucose and sodium to pass through the proximal tubules. The glucose passes out in the urine. That's calorie loss. That's why these drugs are effective anti-diabetic agents. But the sodium is actually where the action happens. The passing of sodium may well be part of the cardiovascular benefits, but it's probably also the mechanism by which there's renoprotection, because the macula densa is a sensing or a part of the tubules that actually centers back and causes the afferent arteriole to vasoconstrict. Tubular-glomerular feedback is what it's technically termed, and you can reduce interglomerular pressure through simply the sodium passing through the tubules and reduce the albuminuria. So albuminuria is protein in the urine, and if it's reduced, it's a good marker, or not absolutely the case, but a good marker that a treatment may well go on to reduce kidney disease progression. And David Price was new to CTSU about this time, and he and I were concocting plans for designs of trials based on the EMPA-REG outcome data, but we wanted to study a much broader range of patients and definitively show these drugs could slow kidney disease progression. Now, we sent a number of investigator-initiated type proposals to companies. It took us a while, but eventually we persuaded Boehringer Ingelheim, and they funded EMPA-Kidney. Now, when we were thinking about how to set up the trial, we went straight to the best trial that had ever been conducted in nephrology. Internationally, we knew we had to try and recruit larger numbers, but we wanted to do it in the same streamlined manner. And so Martin, Colin, and the Sharpette were our inspiration. And we went to the best recruiting regions of EMPA-Kidney, and we added in Japan. There was an interest from the funder to go to Japan. This was a new venture for us in the Renal Studies Group, and actually a new collaborators in the United States as well, who turned out to be fabulous because they ended up almost beating Germany to the post and relegating United Kingdom to third place in the recruitment stakes. But we did manage to recruit, even through the COVID pandemic, 6,609 participants from 241 sites, largely due to the support of our administrative team and Carol Knott. I don't know if Carol's here today. I don't think she is, but supporting Richard and I set up this collaboration and deliver the trial. We averaged 27 participants per site, which doesn't sound like a lot from cardiological perspective, but this is pretty decent for a kidney trial. And just to put that in perspective, this was an industry-sponsored renal trial of the same class of drug conducted just a couple of years earlier, and it was studying 4,500 people, and it required not 8 countries, but 34 countries, and they didn't have the COVID pandemic slowing them down, and nearly 700 sites, so an average of 6 participants per site. So we were beginning to make a difference in terms of the scale that people could recruit at sites by both minimizing exclusion criteria, maximizing the types of patients we could study, but also making it simple and trying to generate data which is high quality by getting large sites to generate data over and over again repeatedly with trained research coordinators. But as I think Martin was describing, all through Sharp, the fear was that the trial might get stopped. And we had this issue all the way through EMPA-Kidney as well, because we knew there was DAPA-CKD, which our arch rival David Wheeler was busy concocting and in the background and leading, and we knew that there was the Credence study, which was already signed and had fully recruited, and they were studying essentially 2 different SGLT2 inhibitors in slightly different populations. Credence studying people just like the losartan population, the renal trial, which has studied losartan population, and then DAPA-CKD had started to look at people without diabetes, but it kept looking at people with proteinuria, and EMPA-Kidney had broadened its reach even further. We were trying to study at least a third with and without diabetes, but wanted to study the full range of albuminuria and levels of kidney function, which we were observing in renal clinics. We wanted to study at least 6,000 people, and it was a very simple design. Standard of care with a RAS inhibitor, of course, where it was indicated or tolerated, then empagliflozin or placebo. And we were going to follow people for 1,070 events. We thought an 18% relative risk reduction was a punt at the time. We thought by studying a drug which lowers glucose in the urine but doesn't do it particularly efficiently in CKD, we were likely to get smaller effects than Christoph Fanner had observed in EMPA-REG outcome, but we still thought an 18% relative risk reduction would be important if it could reduce cardiovascular death or kidney disease progression, by which we mean need to start dialysis, have a transplant, or die from being untreated for end-stage kidney disease, or really important changes in kidney function down to the level of kidney function less than 10, where we'd normally start dialysis or consider it, or important reductions from the baseline value of at least 40%. And the trial was stopped early. DAPA-CKD was stopped early. Credence was stopped early. We feared we would be stopped early, but it wasn't stopped so early that we couldn't generate really important information. So we got to 990 of the 1,070 primary outcomes. So we nearly got to the desired finish line, but we demonstrated a 28% relative risk reduction for the primary composite outcome. And this was really a renal progression trial. As you'll see here, we had a lower than expected cardiovascular death event rate, half of what we were expecting, perhaps secular trends, perhaps COVID, and perhaps we're getting better at treating people in nephrology. But it was mainly a kidney disease progression trial. You can see a clear result there for empagliflozin, a 29% risk reduction. But if you look at the components of the primary outcome, which are most clinically meaningful, dialysis and transplantation and cardiovascular death, there was also a clear 27% risk reduction. So, to the annoyance of one of the New England Journal of Medicine reviewers, we only pre-specified 3 subgroup analyses. We did that just because we wanted to limit the numbers of questions we were asking of the data. And the first of the subgroup analyses was by diabetes status. What we tried to do during the trial, during the COVID pandemic and after DAPA-CKD got stopped early, was to try and steer the trial to try and recruit as many people without diabetes as possible. And in fact, we had just over half of the trial with diabetes, and actually nearly 70% had a non-diabetic cause of kidney disease. So this was really a trial which was really extending to the patients which hadn't been studied in the previous trials. And what was really important here is this subgroup analysis, which suggested that the overall effect was probably the best estimate of the effect in anyone, irrespective of whether or not they had diabetes or not. And this is important because essentially for years we had trying to be argued that there was probably a final mechanism or mechanisms of kidney disease progression. It hadn't been definitively demonstrated, but that schema of a nephron with hyperfiltration was one of those final common pathways. And there was beginning to be good evidence here that not only was there a final common pathway, but that it was also modifiable. So an important result because this suggests they do exist. But this result was the other subgroup which I thought was the most interesting, and this was a complete surprise because if you know anything about SGLT2 inhibitors, you know that the glycosuria levels fall linearly with kidney function, such that below about an eGFR of 45, you get very little effect on glycemic control. They are not anti-diabetic drugs when you get CKD, and down at 20, you're not going to change your HbA1c at all, and you don't change HbA1c in people without diabetes. But nevertheless, what we saw here was a clear effect on the primary outcome across the full spectrum of eGFR. I call this post hoc because we actually expanded the bottom group from less than 20 to less than 20, from less than 30 into less than 20, and then the 20 to 30 group. And you can see that we weren't even beginning to start to see a threshold below which these drugs were not modifying risk. So any amount of SGLT2 inhibitor that got into the tubule seemed to be having an effect. And this really transforms these drugs from being an anti-diabetic treatment, which might benefit the heart and the kidney, into a treatment which is directly there to modify kidney disease progression. What was remarkable about these drugs, though, was that not only that they were highly effective, they were also really well tolerated. At the midpoint of EMPA-KIDNEY, 90% of participants were still taking their treatment. We thought that glycosuria would cause large numbers of urinary tract infections, and David spoke about glycating the kidney and acute kidney injury. In actual fact, we saw no such evidence with urinary tract infections. They do cause thrush, but that can generally be simply treated. We also thought acute kidney injury was likely because of the acute dip in eGFR, but again, to our surprise, we saw evidence that might suggest the opposite. We know these drugs cause you to become very slightly ketotic. That's partly how they work. And we see in people with diabetes that they can get ketoacidosis, but it's rare in people who are treated in the trials. And there had been a sign from one of the earlier trials about lower limb amputation. We didn't demonstrate lower limb amputation risk in EMPA-KIDNEY. But we did want to try and put the results of EMPA-KIDNEY in the context of the other trials. And in parallel with publishing the main paper, we put pressure on Natalie Staplin to try and aggregate all of the data from the 12 other trials which had reported and collected analyses, bespoke analyses from each of the trials. In what wasn't an IPD and meta-analysis, we didn't have time for that, but it was collaborative and based on data aggregated from each trial. And what we were able to do is to try and demonstrate in people with and without diabetes, diabetes on the left, without diabetes on the right, and restricted to the 4 CKD progression trials, the absolute benefits for a year's treatment with an SGLT2 inhibitor. And for the absolute risks in the trials, We could see that in the navy blue, there was a substantial reduction in the numbers of patients with kidney disease progression. We actually demonstrated in this meta-analysis clear reductions of about a quarter in the risk of acute kidney injury. So that's not safety. It started to turn into an efficacy outcome, and we still don't understand exactly how that mechanism works, but it's intriguing and might be something we really have to think about in the, to try and further reduce risk in our patients. But also we see this reduction in cardiovascular death or hospitalization for heart failure in green. And in fact, reductions in hospitalization for heart failure are really quite dramatic. And if you do this graph for the heart failure trials, then the green bar actually goes all the way to the bottom of the slide. So patients with CKD and heart failure would benefit very substantially. But the net harms, the ketoacidosis and potential for limb amputations are clearly outweighed by the absolute benefits. And in people without diabetes, those risks don't really exist. So you almost have all the bang for your buck and no real major concerns in terms of harm. So pretty miraculous drugs for a field, you know, 20 years of hurt, 20 years of negative trials to suddenly be presented with this type of data. And these are landmark data which are transforming how we practice in our CKD clinics. But it was built on the SHARP collaboration. We randomized a reasonably large number of patients. We didn't quite randomize the 9,000 that Colin and Martin have achieved. We would like to try and achieve that, Rich, myself and others in the group one day. We'll try and pass that mark. But what we demonstrated was that empagliflozin safely reduced this composite outcome of cardiovascular death or kidney disease progression. And it did so with relative benefits which are consistent in people with and without diabetes. A surprise that it was so clear in people without diabetes, and even more of a surprise that it was consistent across all of the eGFRs we studied, right down to the levels of patients who are in our kidney clinics. So together with the DAPA-CKD results, SGLT2 inhibitors are the first interventions in to be licensed by regulatory authorities for treating adults with chronic kidney disease. All the previous drugs, the RAS inhibitors, were licensed for use in specific types of diabetic kidney disease. And EMPA-KIDNEY was inspected by the PMDA and by the Chinese, and a lot of work from the team got us through that. But there's also 1A clinical practice guidelines for use across all of the major guideline organizations that nephrology and the cardiology community take notice of. It's also had an impact on our team. One of the things that no one's mentioned yet in this room is the fact that the renal studies group has been mentored by Colin and it's been growing over the years. EMPA-KIDNEY has turned Natalie Staplin probably into the most famous renal statistician in the world. But Praminda Judge is grown up with 3C and has now come back to the team and has been working on eGFR slope analyses and publishing in Lancet Diabetes, providing some evidence with these slightly more sensitive outcomes for the types of data that people are interested in nephrology, the rarer diseases, the glomerulonephritidis, and those that progress more slowly, those with lower levels of albuminuria. Caitlin Main came from Glasgow. We couldn't keep her here. She's going back. She taunts us with her photo on the NDPH website by having Glasgow in the background. But we're now beginning to understand how we think SGLT2 inhibitors work. And then Alistair Roddick, who came here as a foundation doctor, is going to come back to us. He worked tirelessly with the UK Kidney Association with a guideline and also has produced some patient plain language summaries with Anne Whitehouse from the communications team. But the influence of EMPA-KIDNEY goes further because the team are blossoming. Not all of them are junior. Bobby's been working with us for a long time, but it's been an opportunity to renew our collaboration with Bobby Mihailova doing the health economics. The trial's got 2 more years of post-trial follow-up. We want to see what happens because we think that the trial treating people for 2 years may not have measured all the benefits on kidney disease progression and particularly on dialysis. And that's particularly a costly in intervention, both in terms of quality of life, but also health economically. We have managed to persuade companies to start to share individual patient level data. And Zhao Jing, who we haven't got a photo of, she's relatively new, and a new member of Natalie's team is working on that. Nikita is working on the post-trial follow-up, and we hope to report that at the ASN this year. And then Doreen worked on EMPA-KIDNEY and has come back in a lectureship. We've got Rebecca Sandel, who's helping supervising what I call, is it the collective noun for DPhil students, a glut of PhD students who go to formal hall without their supervisors. But we do meet for lunch. But Killian and Greco and Delushi from Ireland, the Philippines and Sri Lanka, respectively, are using the genotyping data, urine sugar biomarkers and proteomics to explore exactly how these drugs work, because we still don't fully understand their mechanisms of action. So the EMPA-Kidney is really helping what I would call this third generation of the family grow. Of course, EMPA-Kidney was built on all the administrative teams across the globe, the 8 countries, and all the team you can see here photographed. But we have to stop and say, is it Colin's day? This is I couldn't find the photo I really wanted, Colin. But I know you like going to Italy, and I know this is the term for grandfather in Italy. The key acknowledgement, obviously, is to you. I think you brought to the field of nephrology the ability to randomize at scale. You brought to me the idea of doing large-scale trials, transformed my career aspirations from wanting to be a nephrologist to wanting to be a trialist. These 2 trials, SHARP and EMPA-Kidney, are landmark trials, but they're genuinely transforming in terms of clinical practice. The first 2 things we put on anyone's prescription when they come to a clinic is an intensive statin, and we look for an SGLT2 inhibitor. I currently feel like there's this third wave of the renal studies group growing. We're all working tirelessly to try and preserve the globe's nephrons. I know that you will be there if we need help. I do hope you do spend some time in retirement. You do manage to go back and spend some time in Southern Europe, and you can reflect on the legacy of the team that's behind the large family. I think it's 16 of people now, clinicians and statisticians working on kidney disease here. We promise to be stubborn and persistent in trying to continue to expand the numbers of patients in trials. And I'd like to thank you all for your support, your mentorship, and for sharing your success with us.
So huge thanks, Colin, and the organisers for the opportunity to speak to you today. So my talk is looking, as David says, to the future. So I don't have lots of exciting data to show you that's been generated by the Renal Studies Group as yet, because this trial is very much in its infancy and due to start in the coming weeks and months. So I'll be talking to you today about aldosterone synthase inhibition and whether it can really delay chronic kidney disease. But targeting this pathway, or targeting the aldosterone pathway more specifically, is something that the Renal Studies Group, Colin, Richard, Will, have been thinking about for many years now, and well before actually EMPA-Kidney was started, and they were busy developing protocols for trials that could target this pathway. And then Christoph stood up at the ASN in San Diego and presented his EMPA-REG data, which sort of enticed us to look at SGLT2 inhibitors, and the rest is history, as you've just been hearing about from Will. But I feel we've gone full circle now, and we've come back to this pathway, and I'll show you sort of how we're thinking about doing that. So apologies to the many nephrologists in the back row who for this slide is very basic and the sort of the foundation of how we practice and what we think about kidney disease. But for those of you for whom it's less familiar, we measure kidney function, as we've been hearing, by checking a blood parameter called creatinine, and that we use to calculate a function called estimated glomerular filtration rate. And many observational studies over the years have shown what the impact of having a declining eGFR is. And for most people, we only really think about the effects from a kidney perspective and resulting in the requirement for dialysis and transplantation, which increases exponentially as you develop a lower GFR. But in addition to the kidney outcomes, there are also many cardiovascular effects, as we heard about from Martin in his SHARP presentation, particularly risk of dying of cardiovascular events, developing heart attacks, strokes, and heart failure. And that's another outcome that I'll come back to in a little while. So in addition to abnormal kidney function being of significant importance, we're also, as kidney doctors, very interested in measuring albuminuria and studying the levels of protein that's leaking from the kidneys into a patient's urine. And albuminuria is a marker of kidney damage. And what you can see here from this observational analyses and the heat map, that as your level of kidney function declines, more important, and as importantly, the amount of protein that leaks from the kidneys into the urine increases, the risk of developing kidney failure increases substantially. So we know it's a very good marker of the risk of developing kidney failure in the future, but it's probably also a marker of cardiovascular disease, although the relationship may not be as causal. And certainly in meta-analyses of randomized trials, a reduction of about 30% in urine albumin-creatinine ratio has been associated with a reduced risk of developing kidney failure. And therefore, nowadays, some trials and phase 2 studies are using urine albumin-creatinine ratio and the reduction in UACR as a surrogate of predicting whether a treatment may be beneficial in terms of lowering intraglomerular hypertension or the blood pressure within the kidney and affecting the renal hemodynamics, and therefore acting as a surrogate of whether we could potentially slow down the progression of kidney function declining. So coming back to aldosterone, so aldosterone, for those of you that are less familiar, is a steroid hormone produced in the body by the adrenal glands, and it acts by the steroidal and mineralocorticoid receptor. In normal physiology, they are both present, but they can get upregulated in many disease states. And both upregulation of aldosterone production as well as activity of the mineralocorticoid receptor can be associated with harmful effects, particularly for us as nephrology. We're interested in the effects on the kidneys, but also on other organ systems. So it can raise blood pressure, it can affect the function of the heart, and ultimately patients will develop heart failure, as well as kidney disease with leaking of protein and developing abnormal kidney function and other effects also. So as Will alluded to in his previous study, we have had treatments for about the last 30 years that target the renin-angiotensin-aldosterone pathway, which is illustrated here. And the drugs that we had were really only ACE inhibitors and ARBs, and Will presented the slide on the renal and IDNT trials for you in his talk. And actually, when I first came to CTSU and worked alongside Colin, my PhD thesis was working on a drug that had some impact on this pathway, sacubitril valsartan, in the UK HARP3 trial. And that was, as I say, RAS inhibitors were really the only treatments that we had until the advent of SGLT2 inhibitors, and you saw the data from the EMPA-KIDNEY trial on the previous talk. Recently, drugs that target or block the action of aldosterone on the mineralocorticoid receptor, such as finerenone, have been shown in patients with diabetes to have beneficial effects, and I'll come back to some of that data in a moment. But in addition, very recently, there's a new class of drugs that's being developed called aldosterone synthase inhibitors, which work more proximal in the pathway and work to block the production of aldosterone by blocking the enzyme aldosterone synthase, which is the enzyme that's responsible for the conversion to aldosterone. There's a few drugs that are currently being investigated for mainly for hypertension, baxdrostat, lorundrostat, and in easy kidney we're going to be testing a drug called BI 690517, and I'll come on to some of the data that's been shown from the studies of this in a moment. So as I mentioned, finerenone is a drug that's been shown in patients with diabetes and kidney disease to have beneficial effects. And this meta-analysis pulled together the results from the two trials, including about 13,000 patients, and showed that targeting this pathway has both cardiovascular and kidney benefits. So as I mentioned, one of the features of advancing kidney disease is development of cardiovascular disease, and certainly as kidney disease progresses, the phenotype and the presentation of kidney disease is such that patients often present with heart failure and structural heart disease and sudden cardiac death. And now we have a drug that here seems to show a benefit on reducing the risk of hospitalization for heart failure by about 22%. So that's exciting news for patients with kidney disease. But also as a kidney doctor, what's important is knowing that there is a drug that also reduces the risk of developing kidney failure. So we now potentially have drugs that by tackling the aldosterone pathway may have beneficial effects on both of the two major outcomes that these patients are at risk of developing kidney failure as well as cardiovascular events. But it's important to note that these trials were done in an era where SGLT2 inhibitors were not widely used, and as you can see, only about 7% of the participants were taking an SGLT2 inhibitor at baseline. Despite these reassuring and exciting results, unfortunately, these aren't applicable to the great proportion of patients that we see in our kidney service, because they did not test patients without diabetes and kidney disease. They didn't test the types of patients that were studied in EMPA-Kidney, so those patients with much lower levels of protein leaking from the kidney, those with lower levels of kidney function, and also those with higher levels of potassium, which is a common feature as kidney disease progresses. So clearly these results are not applicable to the wide range of patients that we see. So I mentioned potassium on the previous slide, and that's one of the concerns that many doctors have, not just nephrologists, but doctors generally have about giving treatments that target the aldosterone pathway, because they do result in an increase in the potassium levels in the bloodstream. However, SGLT2 inhibitors have been shown in meta-analyses to potentially reduce that risk of serious hyperkalemia by about 16%, and therefore, if used in combination with drugs that target the aldosterone pathway, may help mitigate some of the risk of hyperkalemia and help make these drugs more tolerable. So what about the data with BI 690517 in patients with kidney disease? So the drug was tested in about 714 patients with kidney disease. About 2/3 had diabetes and 1/3 without. And these patients were randomized initially to empagliflozin or matching placebo. And after about an 8-week run-in, they were re-randomized again to receive either active or placebo BI 690517 at one of 3 doses, 3, 10 or 20 milligrams. And they were followed up for the primary outcome over a period of 14 weeks for a change in albumin-creatinine ratio. So what did the study show? It showed that after a period of 14 weeks, those individuals that were assigned the 10 or 20 milligram doses of BI 690517 had a substantial reduction in their levels of albumin by about 40%. And that was with the BI 690517 alone. And when you look at the results of those individuals that were taking BI 690 plus empagliflozin, there appears to be a potentially additional benefit in albuminuria lowering. And as I mentioned earlier in the presentation, we particularly are looking for a 30% reduction, and that's to be sort of indicative of what might be clinically meaningful. And those the proportion of patients that had a 30% or greater reduction in albuminuria from baseline was more pronounced in those individuals that were assigned to BI 690517. And although not statistically significant, there appears to be a numerical additional benefit of the addition of empagliflozin on this outcome. So this really takes us onto the rationale for the EASY Kidney trial. We have trials that, so we have the fidelity meta-analysis, which showed that drugs like finerenone do have beneficial effects in patients with diabetes and kidney disease, but clearly they've not been widely tested and not on the wide range of patients that we see in kidney clinics. And these new drugs, the aldosterone synthase inhibitors, provides a new unique opportunity to be able to test targeting the aldosterone pathway in a much broader range of patients with kidney disease as to whether they're safe and tolerable. And here in Oxford, and particularly in the renal studies group, we're particularly interested in testing what the effects might be in the non-diabetic kidney disease population who have not previously been studied, as well as what the effects might be when you combine these drugs with an SGLT2 inhibitor, following on the work from EMPA-Kidney. Also, what happens when you test it in sort of more advanced kidney disease and those patients with lower levels of albuminuria. So moving on to what EASY Kidney will look like. Well, it'll look very similar to EMPA-Kidney and follows on from the foundations that have been built from the SHARP trial and EMPA-Kidney. So we're looking to recruit about 11,000 patients. So we are chasing the tail of SHARP and looking to potentially be the largest ever trial of kidney disease, including about 4,800 patients with diabetes and about 6,200 without diabetes. All patients, participants will be given empagliflozin in addition to RAS inhibition if indicated and tolerated, and they'll be randomized 1-to-1 to BI 690517 or placebo. The trial will be event driven until about 1,070 primary outcomes have been achieved in each of the stratum, and we're aiming to detect about an 18% relative risk reduction based on those data from the Finerenone trials. Our primary outcome is very similar to the EMPA-Kidney outcome. We've got we've got the kidney disease progression outcome, looking at progression to kidney failure, requiring transplant, or dying of kidney disease, as well as the biochemical outcomes, or a cardiovascular component, which also includes hospitalization for heart failure. When each of the stratum have completed, we plan to pool all the results together in a meta-analysis that will hopefully be able to provide much greater statistical power to be able to assess for any key differences on the effects of BI 690517 in subcategories of patients by their underlying cause of kidney disease, their baseline level of kidney function, albuminuria, as well as their diabetes status on these key outcomes, one of which is the overall primary outcome for each stratum, all cause of hospitalizations, as well as all cause mortality. So like in EMPA-Kidney, we're looking for patients who are at risk of progressing with their kidney disease, so all adults, and we will be defining these individuals by their level of kidney function, so GFRs of 20 to 45 or GFRs of 45 to 90 with some degree of albuminuria. So in order to recruit 11,000 patients, we're going to have to spread the collaboration a bit further. So it builds on the collaboration that's been built from SHARP and EMPA-Kidney. So in addition to the countries that were participating in EMPA-Kidney, we're going back to the countries that Colin and Martin initially made collaborations with, including Australia and New Zealand, as well as newer collaborations that have been developed through the support of Colin and his contacts that he's developed over his career, for example, in India, Latin America, and further collaborations in Asia. So really, this is I'm standing here on behalf of the whole of the team, whole of the Easy Kidney team, and we really owe our huge thanks to Colin for all his support with the design, the setup, the numerous and ongoing discussions that we're having with the regulators, as I've already mentioned, support with developing the collaboration further. And this is a photograph from the second ever steering committee meeting, which took place in January, and Colin is the co-chair of the steering committee. So we're hugely indebted to all his support and input, which he's provided over the many years through all of the work that we've all been involved with in the Renal Studies Group and going forward. So Will was talking to you about being able to enjoy your retirement, which we hope that you will do, but we hope that you'll be able to continue providing the support that you have given us always. And I'd like to extend my personal thanks for all of your support, your guidance, your mentorship, your education over the many years that I've been working here in CTSU. So huge thanks, Colin, from me and all of the team.
Thanks, everybody, for coming back in and for moving towards the chairs. Thank you. So having had a fantastic science session, both in the morning and now in the afternoon, about meta-analysis and the clinical trials and the kind of the legacy that Colin has created in this whole area. We kind of move on to the bit where we see how much we can embarrass him, even beyond what happened in the earlier sessions. So there are a few people either online or in videos who just want to say a few words. And we then will give Colin an opportunity to embarrass us back. But first I wanted to hand over to Dr. Hui Nizia, who's just going to say a few words, who's online live. So over to you, Dr. Hui.
Good afternoon to Professor Baigent. I would like to extend congratulations for your long and successful career and to convey thanks for the collaboration between the nephrology units in Malaysia and the Oxford Clinical Trials Unit. It started 22 years ago with the SHARP trial, continuing thereafter with both EMPA Kidney and the EASY Kidney trials. Over the years, it was your quiet but very purposeful guidance that I value and honor, and I hope you will understand it is much appreciated. Thank you and best wishes, Dr. Hui Lai Siong from Malaysia. Thank you.
So hi, Colin, Neeraj Bala here. Just wanted to really say all best wishes with the changing of position to emeritus. I just wanted to say many thanks. Got very fond memories of the time working vascular overviews and on COXIBs and NSAIDs and statins and antithrombotics. And you know, you've helped an awful lot of both patients and clinicians, and you know, supervised people like myself. All best wishes, and look forward to seeing you soon in Oxford. Take care.
Hi, Colin. Wishing you all the best for your retirement, and congratulations on such a stellar career. It's been an absolute pleasure working with you over the past 30 years since the very beginnings of the Cholesterol Treatment Trialist Collaboration. This work has been able to achieve so much in terms of changing practice and lives for people around the world based on the evidence that's been produced and analysed under your leadership. I'm sorry I can't be there in person to help celebrate all of these milestones and to wish you the best for your retirement, but I know you will still keep working a number of things in the future, even after retirement, and I look forward to seeing you for many years to come in these roles. All the best, Colin.
Hi, Colin. It's Adira here. So sorry I can't be there with you and everyone to celebrate an amazing career and your retirement, which is hard to believe. I'm really thrilled to be able to share a personal message. In 2011, we published SARP. I think I've known you since 2005 when we started the whole journey, and that seems like a very long time ago now. It's been a remarkable journey. You have been an amazing leader, friend, and colleague. I personally have been hugely inspired by your kindness, your thoughtfulness, and what you've done to really help us in nephrology get into the big clinical trials world. Certainly across Canada, we would not have had the opportunity to be part of big clinical trials without SHARP and then all the subsequent thereafter. We've had fond memories of meeting first in Oxford and then various places around the world and having conversations. I remember in a small booth somewhere at the ASN where you asked about, what if we tried this? Do you think this would go over? Do you think Canada would be into that study? And then meetings with KDIGO, trying to describe what was wrong with clinical trials in nephrology and how best to move it forward. So thank you. Thank you for all that you've done to mentor and teach me personally, as well as everyone else in nephrology. Thank you for your wanting to make a difference in getting the right evidence to help us take care of people with kidney diseases better and bring us into that clinical trial world. I think you probably don't realize what an impact you have had in your quiet, humble, and incredibly patient way. I really wish you and yours all the best in the next leg of this journey we call life. And thank you very much for being a part of ours. So with that, Colin, happy journeys. And to all of you there, please a toast to Colin on my and our behalf. Thank you so much.
I've been dreading this moment, but today has been very enjoyable. I guess it's a bit like eavesdropping at your own funeral. But thank you for all the good wishes. I shall carry on doing some things, but I am essentially stopping the frenetic life that I've been living up until now. So I'm going to reflect a little. I will obviously say thank you to a few people, but I want to try to get to why I wanted to come here and why I stayed despite everything. And I think it's important that we do reflect on why we're doing things in our lives. So I have to say that epidemiology was not my first choice of career. I'm going to just talk a bit about what I'd originally planned to do before moving on to what I actually did. So originally I wanted to do anything to do with steering wheels. And I did toy with the idea of racing speedboats. Then I got onto cars, but then I calmed down a bit and decided I'd try and do something a bit more conventional. My life was turned upside down in 1979 when, quite out of the blue, at least as far as I was concerned, I was told that I had end-stage renal failure and literally ended up on the hemodialysis the same day. That evening, I started my first dialysis session, having had a vascular access put into my leg in the afternoon, and that kind of experience. I think anyone who's experienced something like that, where they'd been going along just fine. I was doing my A-levels or starting to do my A-levels, and everything came crashing down. And what happened after that was really a change of plan. I'd originally planned, I was interested in mathematics, and that was really what I was good at school. I was planning to apply for Cambridge through the entrance exam. And but because I ended up on dialysis just a few hundred yards away from here, I decided I'd switch and apply to Oxford instead. So that's how I ended up at Oxford University reading mathematics. I dialysed, I'm just going to show you a picture. I actually had to go to the Science Museum website to find a picture of the dialysis machines that the keel on the right, on your left rather, is the old-fashioned dialyzer that was a huge thing that had to be cleaned each time you had dialysis. And then on the right is an example of a kidney machine. I didn't use these in Oxford, but I couldn't find any pictures of the Oxford ones. So this is a cumbersome process that has been made much simpler by evolution and progress since then. The dialyzers are now tiny and the machines are wizzy now. So it wouldn't be the same experience now. But at that time in 1979, it was quite a process going through dialysis, and I found that very tough. But I was very lucky because I only dialyzed for just over a year before the first transplant, my first transplant came along, and almost immediately I experienced a return to better health. It took me some time to get really into it, but fortunately I had my transplant during the year between school and coming to Oxford, so everything worked out really nicely. And so I began to realize that I could live a completely normal life. I played squash at university and participated in everything. And I've essentially thought of myself as being completely well, really, for most of my adult life. But one has to recognize that much of my interest in medicine derived from that experience. So although I originally planned to do mathematics or some related topic, I ended up going back to medical school, and in the years between 1984 and 1989, I trained in medicine. I then went on to do my clinical training in Oxford and then Banbury and then Birmingham, where I didn't see Martin, but I think he might have been there at that time. Certainly, the people who influenced us both were there. And then, quite by chance, in 1991, there was another change of plan. Life is punctuated by changes of plan, and you have to, so I've learnt, ride with it and see where it goes. So what happened in 1991? Well, I met Richard by chance, and it was really a complete chance, because my girlfriend wanted to visit her music teacher in Jericho, and I reluctantly came along with her, and we got talking about what I was doing and how I wanted to maybe consider changing direction. Didn't really enjoy clinical medicine very much, and I said I was interested in epidemiology, and she said, "Oh, you should meet Richard Peto," and phoned him up there and then, and Richard, you probably don't remember this, but you came round to Margaret's house, you put me in your car, terrifying experience, but we went round to Banbury Road, and you gave me a stack of papers, and we came back, and I said, "Well, do you think there might be any chance of positions at CTSU in the near future?" And Richard said, "Well, there might be, but of course it would be subject to a rigorous review process and an interview." That's when I realized Richard's use of irony. So, as you've already heard from Rory, I eventually arrived on the worst day in his life, and probably made it a whole lot worse. But anyway, I ended up here. Why did it suit me so well? Well, I think the first thing is, it was quite clear right from the very beginning that Richard and Rory were really only interested in asking big questions and answering them clearly. And they didn't really care how long it took. It was long-termism rather than short-termism. This rush to write many papers in your career. It never interested me, and I don't think we were encouraged to do that. We were encouraged to tackle big questions. And I was very fortunate in meeting Richard and Rory early on and having that drummed into me. Later, of course, I met others who were in the room, and I really value their collaboration over the years. But that was the thing that attracted me. And I wanted to answer question. I was less interested in discovering risk factors. I was more interested in finding out how you actually dealt with a disease, how you reversed it, how you treated it. And that was when Richard's insight into randomization really struck me. And I particularly like the poem The Flight Path by Seamus Heaney. And he talks about his father doing some origami, and all of a sudden the bird or whatever it is his father's making appears, and he says, "A dove rose in my breast." And this honestly is the experience that I had when I first started thinking about what sort of studies we needed to do to try and tackle some of the big questions. And it was Richard and Rory who inspired that. And so, is that my time up? This feeling, I had it. My dad used to make things for me. I had the same feeling, and ever since I've been trying to recreate that feeling in the work that I do and the work that I do with others to try to make a problem clear, make things transparent so that even a layperson can understand what is going on with the data. So that's the best I can describe it, that feeling of excitement when something emerges. So really, just like everyone else, epidemiologists are adrenaline junkies, but the adrenaline comes once every decade. So what was it that was the insight that really I felt was so key to me? And this was the idea that treatments really had, at least of major diseases, looking at major outcomes, the treatments are at best moderate in size. And this is so true. Even now, I have people telling me that don't worry, the new drugs coming along are going to reduce mortality by 60, 70%, and we won't need to do big trials anymore. Even now, we hear that because we're going to be able to genetically engineer drugs. I think this insight that we have here is likely to remain true for many years to come, and I don't see it changing. So if you're going to try and detect moderate effects, you've heard all this, of course, you all know this. You have to make sure that the systematic errors, the biases are, and random errors, their chance is much smaller than what you're trying to measure, the difference between moderate effect and no effect. And so you need to be able to detect such effects, you need randomized and large studies. It's a very simple insight, but that insight has driven me for these last 30 odd years. And the insight that when you have such studies, especially when you have such studies and you have many of them and you can put them together in a meta-analysis and you can organize the data in ways that allow you to gain insights, that's just the perfect way to try to work out how to treat patients. So I talked about a dove rising in my breast. Well, this is an example of just such a beautiful piece of work. It's not, of course, something that we've done here, although Zhenming extended this line down below 4 in the China Kadoorie study, or in Chinese study, not the Kadoorie study, another Chinese study. And so to me, this was a big step forward in thinking about cholesterol, because it helped me to understand the trials. Because if you know that each 1 millimole increment results in a doubling of risk according to the observational epidemiology, then if this is a causal relationship, you would expect when you look at the trials to see this type of pattern whereby the smallest reductions in LDL cholesterol result in the smallest reductions in risk, and vice versa, large reductions lead to large reductions in risk. So if you're presented with a diagram showing all the results of the statin trials, scrambled, not ordered in any way, you wouldn't be able to make sense of it. Once you allow for the fact that variation will be expected because of this phenomenon, suddenly it all becomes clear. And it's that flash of almost, it's a surprise that when you're expecting it, or you were hoping it was going to be there, but when it appears in front of you, it's that excitement that has always driven me. And I'm not going to talk about this particularly, but you see the same thing when you look at the more versus less trials. And then, I mean, this owes to some of the work done by people on the CTT, together with our colleagues in Australia. We heard from John Symes. They've collaborated with us on this for many years. But by organising the data for the CTT, we're able to say what happens when you lower LDL cholesterol, even among those with the lowest LDL cholesterol when they're starting. You know, years ago, no one would even think of lowering cholesterol in somebody with an LDL of say 2.5. It just wouldn't have thought about that. But now we know from the CTT and from the newer trials that start off at lower levels with the PCSK9 inhibitors, that actually you continue to reduce risk. So if you're at high risk, but you have average or below average LDL cholesterol, then you can reduce your high risk by lowering cholesterol. And it might be particularly easy to do that with a simple drug like a statin or a combination or a PCSK9 inhibitor. So to me, the work of organizing the data in a way that throws up this revelation is all worthwhile, because that has been so influential in cardiology over the last couple of years. Moving on to mortality, what we talked a bit earlier, some of the speakers spoke about the distinction between coronary disease and non-coronary cardiac disease. That was partly inspired by this finding in the CTT, when we saw that if you classify causes of death carefully, there did seem to be this distinction between the two types of death, which would be expected if atherosclerotic mechanisms are not involved in other cardiac deaths. So that was a clue. The other thing, of course, about this diagram, which Kirsty has already shown, is that there was absolutely no evidence of any non-vascular hazard. And again, that's extremely important. And further work that's been done now, looking at adverse events, supports that for non-fatal events. So coming back to me, we talked about. I just wanted to get over that excitement, and I believe we all have to have some excitement in our careers. So getting results like that, I think, is extraordinarily important. But if you work on important things, then it's even more exciting. So what happened then was that in 1994, actually at the same time that John Dinesh was training with me here, we both went to the London School of Hygiene to do an MSc in epidemiology. And during that time, my first graft, my first renal transplant, failed completely, and I was off from the school for a while, and literally on the day that I was due to restart dialysis, I had a telephone call informing me that there was another transplant available for me. It was a perfect match, and I think that just illustrates how jammy I've been in my career, really, quite honestly, because that was perfect timing. It took me very little time to get over the operation. I went back and completed the MSc, but it made me stop and think. It was another turning point in my life, because I thought, well, I've got to do a thesis, and I had a very short time to do it. What am I interested in doing? And I'd been thinking about the things that David had been talking about, and was particularly struck not by this, because this didn't exist in 1995. Rob Foley did this a few years later, but similar data, just actually done by Stephen McMahon, showed that the mortality excess in dialysis patients was extraordinarily high. And if you're an epidemiologist and you see a relative risk of 30, then you sit up and take notice, don't you? You think, well, what the hell is going on here? And I said earlier my thesis was rubbish. Well, essentially, the idea I had was that this was all going to be due to coronary disease, because obviously these patients had lots of risk factors, and by giving them a statin, you'd reduce risk, and it would all be very simple. But of course, it didn't turn out that way. As you've heard from Martin, we realized pretty early on that quite a lot of the mortality was actually nothing to do with coronary disease. And that's when it became interesting, because we then realized that if you were going to treat patients with a statin, first of all, you had to have a large LDL reduction. And secondly, you had to have a large trial, because the event rate wasn't going to be as high as perhaps you might expect. And at the time we were ridiculed. Actually, some people say the trial was too big, and some people said it was too small. And so we thought, well, it must be around about right. And we just about got there. I mean, you know, the p-value of 0.002 is not, it's not that extreme. So even 9,000 patients was just about enough. So on this pie chart, you'll see the acute MI part of mortality in dialysis patients is only about 8%. The rest of it is either non-cardiac. Sorry, this is all either non-vascular or to do with this cardiac muscle. And we've learned from trials in heart failure that there was absolutely no effect of statins on sudden arrhythmic death. So there's the Corona and GC heart failure trial, no effect on sudden arrhythmic death or on worsening heart failure. So we knew that we were onto something in just making sure we understood what proportion of events in CKD we were likely to be able to reduce so that we get the power large enough to detect something overall. And this was another dove moment for me. And I remember Martin and I were at the podium together in Denver. And it was Martin's idea, actually, I think, to do a bit of a tease. So we actually rolled out the purple line slowly so that people couldn't see what the pattern was. And we got a standing ovation. I don't think I've ever seen that happen in any meeting, but it was a very exciting time. But there was a disappointment in Sharp because there was this idea that glomerulosclerosis had a similar etiology to atherosclerosis, in that people had seen foam cells in the glomerulus and thought that maybe you could reduce the risk of progression by lowering cholesterol, but it turned out to be not the case. And if you're a kidney patient, the one thing you want to do is avoid dialysis if you can. So delaying progression of renal disease is a very important outcome. And that's what we did with End the Kidney, what Will Harrington and Richard Haynes and the team did, showed very convincingly that following on from the work by Christoph, you can delay progression by using empagliflozin. And actually, I suppose it's not really a big secret, but I started empagliflozin the moment that I thought it decent to make the request of my nephrologist, and you see some of them sitting at the back there. But the impact on the rate of progression of disease, and I remember I'm a transplant patient, there weren't any transplant patients in EMPA-KIDNey, but it changed the trajectory very rapidly. And so currently my renal function is stable. It's terrible, but it's stable. So I think my lucky stars for that. I think I've generally been extraordinarily lucky in my career to have gone for the whole of my adult life in relatively good health, thanks to transplants and the care of the Oxford Kidney Unit, but also to have met Richard, survived the journey from the house where we met to Danbury Road and back, and just generally, it's been a blast. I'm going to probably forget people. I make the confession now that it's likely that there are people who have helped me a lot who are not on this slide, but I'll try to cover the general spirit of my thanks. Richard and Rory, thanks for giving me a job. You know, they have a reputation for picking up all the wastes and strays from the different areas of medicine or astrophysics or whatever it is. We have loads of people here who've done something different and then realize what their true vocation is, and I'm one of them. I'd like to thank, just to make the point that the admin team make it all possible for us. Chris, Anna, and the other Anna. Thank you very much for all that you've done over the years. I don't know, I can't see any of them here. Are they there? Oh yeah, there you are. Thank you. All those grant applications that I gave you 3 days after they were due. Never a crossword. It's just amazing what you do. And I'd like to thank Mike Hill for the work he's done in the lab. Really, I remember when it all started with Linda, and you know, it made the lab a world-class environment. So thank you for all the work you've done on our studies. The IT team is now led by Eamon. I'd just like to mention one person in particular, and that's Alex Baxter. I don't know if he's here, but he's a genius programmer, and there's no way we would have got anywhere with HARP or even perhaps the vascular overviews without Alex's help. He really helped sort out how to do things and still does. The communications team have been fantastic. When I first took over the MRC Population Health Research Unit leadership, the MRC hounded me for a report on our communications, and it was a complete nightmare. When Anne Whitehouse arrived, she was my savior, and I'm very grateful to her and to the team for taking over that part of things, which I have to say I didn't really enjoy very much. So on to the vascular overviews. I mean, this has been a huge part of my life, but I say it's in teamwork, and I really, if you try and think about, would you have been able to do something without a particular person, then it's quite hard to think of anyone really who wasn't an essential part of the team that allowed us to do some of these remarkable studies together. So Kirsty Reith is now leading vascular overviews. And over the years, we've had, and Heather Halls and Kate Bird are still working on it. Lisa Holland, Kelly, moved on to other things. And also we've had David Price working on the diabetes stuff, and more recently on other stuff. And Jane's always been very supportive. Statistical support, we've got Lisa Blackwell, who's been an amazingly diligent checker and producer of figures, and thoughtful person when it comes to thinking about manuscripts, and of course led by John Emberson, who we've heard from already. The renal studies group now is led by Richard and Will, and Parminder is in the wings, gradually taking on more and more. And I think we can think that the renal studies group is now in good hands. But I would also like to specifically mention Martin Landry, because without him coming to Oxford when he did, I don't think any of the renal studies group would exist. He really took it by the scruff of its neck and made it work. So thank you, Martin. I need to say thank you to all the students, past and present. I'm delighted to see some people who've come back for the day, and it's been lovely to see people. And good luck with your careers. I'd also like to mention that during COVID, Barbara Cassidy persuaded me to take on chairmanship of the clinical practice guidelines and for the ESC. And during that time, Valentina Torsini, who's sitting in the front row here, who's the chief scientific officer of the ESC, was enormously helpful, and we had a great time working on the CPG together. So thank you very much, Valentina. I've already thanked the Oxford Kidney Unit. They've all been fantastic over the years. They've all been pretty permissive, and they've allowed me to get on with my life and just keep me going. So finally, and apologies if I've forgotten to mention you by name, I'd like to thank all of my collaborators and senior colleagues, the speakers today, the chairs who come, and I'd like to thank the organisers for the event. So Kirsty Reith in particular has led the organisation. Hannah has been enormously helpful. There's one other person I want to thank, which I don't think she's here, is MZ Nicholson, my PA, I share with Rory. She's coming to the dinner, so I'm going to surprise her tonight with some flowers. So hopefully we can all, those of you who are coming to the dinner, I look forward to further conversations, discussion. But thank you everyone for making this such a memorable day for me. It really has been extraordinary. Thank you.
Yeah, I'd too like to thank the organisers of the meeting. I think it's one of the best scientific meetings I've been to in ages. And I think also what it did was it described the impact that Colin has had and the impact that Colin will have in the future. The impact he's had in terms of changing people's understanding of what needs to be done, supporting, mentoring, creating an environment in which those things can be done. And so I think we're only halfway through the story of Colin's impact on health nationally, internationally. And I'm really grateful to all of you for coming to share today with all of us and to help thank Colin for everything he has done and everything that he will make happen through what he has done. And we have a small memento for him to remember today, remember us, and if you don't retire, you have to give it back.